Now you can start.
Good evening, everyone. I would like to welcome you for this interesting webinar on Hope After Loss Navigating Recurrent Pregnancy Loss. But before we delve into this academic activity, I, on behalf of IFS, BOX, and SRMS IMS, would like to pay my sincere condolences for all the precious lives which were lost in the unfortunate crash of Air India on 12th June 2025. Saddening and heartbreaking indeed. But life moves on and we need to do what is planned. So, to continue with our webinar today, I would just give a little brief introduction that this webinar is being organized by IFS UP West in collaboration with Box,
सब्जी फल दाल दलिया खिचड़ी सब दे दी
hosted by SRMS IMS, Bareilly. We have had the special privilege to invite special interest group early pregnancy for this webinar. It is the vision of Dr. Pankaj Salwa sir and Dr. Shweta Mittal madam which inspires us to keep on conducting these scientific endeavors. And to begin this event, we would do a small virtual lamp lighting. For this, I would just share my screen.
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
After the blessings of the Almighty, I will first invite our past secretary and executive advisor of IFS UP West, Dr. Shashi Bala, to say a few words. She is professor and head of Obscene Gynae Department, SRMS IMS Bareilly, and has many publications and awards to her credit. She always plays a pivotal role in these academic activities. Over to you, madam.
Madam, thank you, madam, for nice words. Good afternoon, everyone. We are privileged to have very prestigious people in this group. The madam, Picky madam, she's a central body from IFS. In absentia, I would also like to welcome Professor Talwar sir, Madam Shweta Goyal sir, who is here with us to bless all of us. Without his blessings, we could not have this webinars or any kind of CME would not have been possible, at least in SRMS, sir. I welcome you, sir. And I would also like to welcome the executive members, and the president of Bareilly Obs-Gynae Society, Madam Latika. I would also like to welcome Madam Neera, Madam Anita Nath, and Madam Mridula. They are the big figure in Bareilly Obs-Gynae Society, and without their support also, we could not organize these kind of events. The topic has been well selected, that is recurrent pregnancy loss, and we all know the recurrent pregnancy loss. It is very frustrated condition for the couple who has conceived after little efforts, or the most frustrating in those patients or couples who have conceived even after ART. And the recurrent pregnancy loss is a gray zone area. There are many questions which needs to be answered, and it is an area for research. So we all, the panelists, have joined together. The panel moderator have really worked hard under the supervision of our very hard-working secretary, my senior, Dr. Ruchika Goyal. She is giving full dedication to this society and to her work. I would also like to welcome Dr. Ruchika for this podium and arranging such a wonderful workshop or this webinar. Though it is online, but the registration is also quite a lot. And I bless all of you for this wonderful this webinar. Without wasting much of the time, now I would like to hand over this mic to the Madam Ruchika Goyal.
I would like request
Dr.
you,
Ruchika,
ma'am,
the
to please
mic is
introduce.
all yours.
I would
So
like to
it is just
introduce.
my honor to
Request you to
introduce my
introduce.
mentor and my teacher. Yeah. Okay. So it is really an introduce my mentor, guide, teacher, and a fatherly figure to me. He is always there to support all of us and by heart. And sir has many accolades to say. And as you can see on this slide, he is a personality beyond imagination and yet so humble. So that is the virtue of our sir. And whenever we remember him, he is there for all of us. What could be more than that for us, sir? So we welcome you to bless us, and your blessings are really matters to each one of us in this department.
Thank you very much, Dr. Sashibala. I am really humbled.
Thank you, sir.
To hear all these things. I had always been a part of that and continue to be a part of that SRMS. And I compliment and congratulate the organizers for conducting such a wonderful webinar on such an important topic. Then I will, as you all know, that recurrent pregnancy loss is a great distressing problem to a couple. And in all these cases, it affects about 1% of the total women in reproductive age group. And in 50% of the cases, cause remains unanswered and all. You can't find out a cause. And in most of the cases, this ASRM also that defines that with the current recommendation, 2 or more pregnancy losses, consecutive pregnancy losses is to be called as recurrent pregnancy losses. And this includes all that pregnancies, those who are spontaneous as well as those who are conceived with ART. Excluding all those pregnancies that if identified that ectopic pregnancy as well as vesicular mole and that of that implantation failure. You know that most of the cases, there may be that causes may be there, chromosomal abnormalities may be there. Then other causes like that uterine abnormalities, cervical abnormalities, endocrinal disorders, then immunological disorders may be there, that inherited thrombophilias, infections, systematic causes, though so many causes are there. But in 50% of the cases, you are not able to find out any cause and all. While evaluating a case of RPL, one has to go for detailed history. That is very important to be taken to. One has to know about the in the pre-pregnant state. If you want to go for assessment and all, you have to ask for that period of gestation of that previous abortion, and that is very important. Pregnancy loss, that is very important in the first trimester and all. And especially the biochemical or an embryonic pregnancy, that is more likely to go in favor of that chromosomal abnormalities. And if that fetal heart activity is established and all, then it goes in favor of that antiphospholipid antibody syndrome. Then if there is a rupture of spontaneous rupture of membranes followed by spontaneous abortion, relatively paleness and all, that goes in favor of that cervical insufficiency. As well as one has to exclude if there's a live fetus and all, that goes in favor of cervical insufficiency plus that uterine abnormalities and all, whereas dead fetus goes in favor of antiphospholipid antibody syndrome. So all those
Yes, sir.
details, that is very important to be taken to, and detailed physical examination in reference to the endocrinal disorders and all that has to be seen to. Then detailed that pelvic examination is to be done too, and for the investigations and all, one has to go for that. Those investigations which are must and all, if the history is in favor of the antiphospholipid antibody syndrome, then karyotyping that is required to be done too. Then in the cases the ultrasound, the 3D, that is to exclude that, or cervical length to exclude that's cervical insufficiency, that all has to be done too. And management, by and large, it is that supportive. 75% of the cases goes for successful pregnancy. With the supportive care itself, tender loving care is the most important, because these people, they are quite anxious and all. They require psychological support and all. Specific treatment that is required, where you want to find out the cause and all, that will be discussed in detail by that speaker. So I won't go in. So most important is that tender loving care. That is most important.
Yes, sir.
To go for a successful pregnancy in the next. Thank you.
Yes, sir.
Thank you very much.
Thank you so much, sir. Thank you for nice words and elaborating what is RPL in a short time. Thank you so much. Now I would like to introduce, should I introduce?
Yes,
madam?
yes, that is what I am going to say. Introduce.
Now I would like to introduce, and it is my honor and privilege to introduce Dr. Pikki Saxena. She is a director, professor, and unit head in the Department of Obstetrics and Gynecology. And she has edited many things, and she has earned 34 gold medal in national and international conferences. I would like to give a big hand to her. What a
Thank you,
commendable
ma'am.
job madam has done, and she has so many things to narrate. So without wasting much of the time, I would like to hand over the mic to madam to elaborate and to discuss and to open up many knots which are there in RPL. Thank you.
Ma'am,
And I would really, by heart, I would like to welcome you once again.
Thank you. Thank you.
नहीं मैम का भी वर्ड्स वो है टू इंट्रोड्यूस हर लेक्चर, फिर बाद में सेकंड टाइम वो होगा.
Okay, okay, madam. So
Okay.
mic is all yours. Just please
Thank
bless
you,
us.
Dr. Shashibala, Dr. Ruchika, for such a warm welcome. And this program, Hope After Loss, Navigating Recurrent Pregnancy Loss, I think it's a very pertinent topic, because as Dr. J.K. Goyal has introduced already the subject and the important points he has enumerated that we need to take into account, we will be starting the deliberations on this. But first of all, I'll take this opportunity to thank Dr. Professor Colonel Pankaj Talwar sir, who is our president of the IFS. He's such an encouraging person, a very positive and progressive person. And Dr. Shweta Mittal, who is Secretary General of IFS. On behalf of them, I want to thank you all for organizing this important program with SIG Early Pregnancy. I'm the convener of SIG Early Pregnancy. And my co-conveners are Dr. Bindu Bajaj and Dr. Anupma Gupta. Dr. Sohani Verma is our mentor. So this SIG is very, very important, because as we now know that all the organogenesis of the fetus starts in the periconceptional period only. And now we have the inverted pyramid of antenatal care, which is going to be deliberated today. And if we are able to optimize blood pressure, sugar, anemia, thyroid, and all those PCOS related hormonal imbalance, then the baby is going, the pregnancy outcome is definitely going to be much better. And the intergenerational transmission of these NCDs, particularly diabetes, hypertension, all these will be avoided. So it is very important and very essential that we take this important period into our main focus, and we lay emphasis. And I congratulate Dr. Ruchika and Dr. Shashibala and Sir, Dr. J.K. Goyal Sir, for this opportunity and for selecting such an important topic. And all the three topics are very good. And I think panel discussion will be extremely nice. So again, my humble regards to Dr. J.K. Goyal sir, Dr. Shashibala Arya madam, our past secretary and advisor, and also all the other dignitaries, Dr. Mridula Sharma, Dr. Mridu Sinha, Dr. Latika Agarwal, President Box, and Dr. Anita Nath. Thank you very much, and it is a pleasure to be here with you today. Thank you.
Thank you, ma'am. So to begin with our academic session, we all know we all we all know that these type of platforms help us bring experts from distant places to clear doubts and update us on the latest informations which on also on topics which are still controversial. So to begin with our first session, I would like to invite our esteemed chairpersons. First of all, I would invite Dr. Godavari Joshi ma'am. She is professor and head of department Obs and Gynae, Government Medical College, Haldwani. Madam is a gold medalist and vice president of Haldwani Obs Gynae Society. She has an experience of more than 20 years and many national and international publications. Her field of interest is vaginal surgery and high-risk pregnancy. Welcome, ma'am. Our next chairperson is a personality which needs no introduction, Dr. Mridula Sharma, madam. She is an senior experienced obstetrician and a director of Dharmdat City Hospital. Besides her vast clinical experience and organizational skill, she is a philanthropist at heart. Her actions speak louder than her words. And she is managing a school in rural area of Mirganj, Bareilly, which is imparting education to more than 800 underprivileged girls. Welcome, ma'am. Next, our esteemed chairperson, Dr. Pragati Agarwal, madam. She is the director of Pragati Hospital. She is a very senior obstetrician and gynecologist and has been instrumental in organizing various national and state level conferences. She has held various posts and has been invited as faculty to various national conferences. It is over to you, ma'am, and then the questions can be posted in the chat box to be answered later on. Dr. Godavari, madam?
I think she still has to
Yes.
join.
Yes, I am here.
Thank you.
Good evening, everyone.
Hi, Dr. Godavari. Welcome.
Hello, madam. How are you?
Good, good.
Hello.
Good afternoon. Good afternoon.
Good afternoon, sir.
Good afternoon. It's so nice to see everyone
Good
here.
afternoon, madam.
So I think today we have very good topics in our basket, and though they appear that we are these topics are always getting repeated, but then कहते हैं ना कि हमेशा कुछ ना कुछ सीखने को होता है, and there is so much to learn every time. Recurrent pregnancy loss, newer frontiers in diagnosis and management. We have been knowing the traditional causes of the RPL, and in spite of knowing all the traditional causes, we see that about 50% of them still remain unexplained. So here today we have gathered here to know more about the newer frontiers in diagnosis, whether we are talking about the pre-implantation genetic testing, or we are talking about the endometrial immune profiling, or next generation sequencing, or advancement in the management, where we have any immunomodulatory therapies, low dose anticoagulation, and so on and so forth. So we have an expert to talk about it over here and to shed more light on this evolving and multifaceted topic. We are privileged to have with us Dr. Piki Saxena, who is a distinguished expert in reproductive endocrinology and infertility. With her extensive clinical experience and ongoing research in the field of recurrent pregnancy loss, she will guide us through the latest diagnostic tools, evidence-based strategies, and promising that are promising newer interventions that are redefining the management of RPL in today's clinical practice. So welcome, Dr. Picky, for such a topic which we know a lot and yet so much to learn. So I would say the platform is all yours, and let's begin with your deliberation.
Thank you, Dr. Mridula. I think you have already introduced the topic. Are my slides visible?
Yes, ma'am.
Yes, they are. They are.
And Dr.
Everyone is
Mridula, it is
requested
so
to, they
nice
should
to,
mute themselves so that we could hear Madam well.
Dr. Mridula, it is nice to notice that you have been at Safdarjung and also at Lady Harding, both my institutes. So I'm really happy that
So we have yet another connection.
yeah.
So nice to know that.
So without wasting any time, I will be starting with the talk. Is it in this? Yeah. So let us see what the miscarriage is. We are all every day hearing so many seminars, webinars about RPL, but still it is very frustrating. It is a very challenging situation, not only for the obstetrician, but also for the couple. So there are so many irrational investigations which are being done, and lot of treatment is being tried. So let us see by evidence what all things are to be done. The SRE 2023 has enumerated some guidelines, some investigations which are must to be done. Some are conditional and some are to be avoided. So we should all be clear, and we should not waste time and money of the patient on waste our resources for doing unnecessary investigations and management. So let us see if we can let us update ourselves.
Are your slides full screen?
Yeah. Is नहीं दिख रहा क्या full screen?
पता नहीं, मुझे नहीं full screen दिख रहा. Maybe others are seeing full screen.
Full screen दिख रहा है मैम.
अच्छा, okay.
Okay.
एक बार वो करें. वैसे तो full screen आ रहा है मैम का.
Should I stop sharing and दोबारा से करूं क्या? या is it
आ रहा है. ये ऊपर हम लोग की गैलरी है ना, इसलिए थोड़ा सा लग रहा है.
अच्छा.
ठीक है.
So I'll just continue. So what is a miscarriage? It is generally a pregnancy which results in the death and expulsion of the fetus or embryo before 20 weeks, or if the weight of the baby is less than 500. This a definition was given by WHO, and nearly 10 to 15% of pregnancies result in spontaneous miscarriages. And as Sir has enumerated, it is only 0.5 to 2% of pregnant women who are facing recurrent pregnancy loss. So the slide has stopped moving. So there are still, even the definition of RPL is still confusing, and there are a lot of controversies. According to ASRM guidelines, 2 or more pregnancies constitute RPL. However, RCOG says that recurrent miscarriage is defined as 3 or more first trimester miscarriages. And SRE 2023 says 2 or more intrauterine pregnancies, and ectopic molar pregnancies are not included. Sir had also enumerated the same. So now coming to the etiology in very brief, some of the factors that we can take care of and which constitute a big chunk is the endocrine factors, which constitutes about 17 to 20%, autoimmune 20%, anatomic factors 10 to 15%, genetic factors constitute only 2 to 5%. And the biggest problem is that we are not able to find any cause for unexplained, or this is known as the unexplained RPL, including the non-APLA thrombophilias. So coming to the endocrine factor, what the SRE guidelines say is that thyroid stimulating hormone should always be tested, and TPO antibodies is recommended in women with RPL. Abnormal thyroid stimulating hormone should be followed by T4. If the TSH is beyond to 4.5 or 5, then we should get a T4 and T3 tested also. However, PCOS, androgens, LH, these things need not be tested for. We are many times overwhelmed by PCOS, and we try to see if that is responsible for abortions, and many times it is. But the ASHRAE guideline says that the fasting insulin, fasting glucose, luteal phase insufficiency, androgen or testosterone testing, LH testing, ovarian reserve testing should not be done. They even say that prolactin testing should be not be done. However, I feel that in patients who are having galactoria or have a previous history of high prolactin, that should be optimized, because first of all, the patient won't conceive. And even when she does, then there may be a decrease in the amount of progesterone she's forming, and that can lead to abortions. But this is what is given in the ASHRAE guidelines. Coming to, we know that if the TSH is more than 10, all the time we need to treat it. Subclinical hypothyroidism is when the TSH is between 4.5 to 5 milli international units. With normal free T4 levels also, they say that these need to be treated by levothyroxine treatment, and we should keep the limit as 2.5. Whenever the TSH level is more than 2.5 milli international units, whether it is infertility or recurrent pregnancy loss, it is better to give levothyroxine treatment. So this was an important paper where effect of levothyroxine treatment in IVF patients was given in infertile women, and it was seen that the embryo implantation rate was 26.9% in those where thyroxine treatment was given, whereas it was only 14.9% in the controls. I'm sure all of us have witnessed this, and we are all testing for TSH. If it is high, then TPO antibodies, T4 should also be done, and this can be easily treated before the patient conceives. So coming to the anatomical causes, which is another big chunk, and it can be treated. So what they say is that all women with RPL should have a assessment with uterine anatomy. First of all, I feel 2D ultrasound should be done. And if there's any abnormality detected, then 3D ultrasound has an excellent sensitivity and specificity to distinguish between septate uterus, biconjugate uterus, whether the cervix is also duplicated, and also to check for adenomyosis, whether it is adenomyoma, for fibroid mapping. Now there is no need to go for MRI, which is very expensive and offers no additional benefit as compared to 3D, which is simple to do and it is cost effective. However, if 3D is not available, then MRI should be done. Then they also say that sonohystrography is more accurate than HSG, and it should be done to evaluate uterine morphology when 3D ultrasound. In many of our institutes, we do not have a 3D ultrasound, so we can do a sonosalpingography, which we are already doing, and check for any polyp or fibroid, all those things, or adhesions. All those can be detected by these. So a 2D ultrasound is also suggested for checking for adenomyosis, and we can differentiate between fibroids and adenomyosis by putting a color Doppler on it. For the postgraduate students, the fibroid will have a peripheral single vascularity vessel running in the capsule, whereas adenomyosis, there are so many features, but it is highly vascular and a lot of myometrial cysts are there. Then another important thing is to distinguish between septate uterus and biconjugate uterus. So these are the important bodies, the ASRM, ASHRAE, and the QME. These three guidelines have been given, and we should look for the indentation in the external contour and the internal contour. So according to ASHRAE, if the external contour is less than 50% and the internal contour is more than internal contour indentation is more than 50% of the uterine wall thickness, then it is labeled as a septate uterus. ASRM is very simple. If the external indentation is less than 1 centimeter and the internal indentation is more than 1.5 and the angle is less than 90 degrees, then we say it is a septate uterus. So there are a number of papers, and we are all doing hysteroscopic removal of septum in patients who are having previous history of abortions. So all these papers are already there, but there was one single RCT which was in the literature. There is still now only one single RCT, and RCT, as you know, is the level 1 evidence, which was septum resection versus expectant management in women with septate uterus. International, this was a multi-centric open label randomized study. That means it has a very high level of evidence. So ESHRE has included this in their guidelines, and on the basis of this, does septum resection improve reproductive outcomes in women with septate uterus? They say it does not improve reproductive outcomes in women with septate uterus. However, I'm sure most of us clinicians have seen that either these patients don't conceive, or if they conceive, they may have abortions. So if we are not able to find any other cause, it is better to do a septal resection. So only on the basis of only one small RCT, which showed no benefit of using hysteroscopic septum resection, they say that it is a conditional okay recommendation for doing it. Metroplasty, however, is not recommended for biconjugate uterus, uniconjugate, or didelphys uterus. And they, again, this is very strange. They say there is insufficient evidence supporting hysteroscopic removal of submucous fibroids or endometrial polyps. So again, I beg to differ, and we have seen that it is better to do a hysteroscopic submucosal fibroid removal or polyp removal for these patients, because if the implantation occurs on these, then the chances of abortion are more. And even if the implantation is not occurring on these, the increased secretion of cytokines, prostaglandins is going to cause a problem. So they say that surgical removal of intramural fibroids we are not doing, is not recommended. Subserosal intramural fibroids should not be removed. And they also say that there is insufficient evidence in the benefit of surgical removal of intrauterine adhesions. This is also, skeptical, because if the implantation occurs on this, the baby may not grow up, the pregnancy may not continue. Look at the EA serum 2016 is the latest one on RPL. They say that some limited studies indicate that hysteroscopic septal resection is associated with reduction in miscarriages. And commonly used techniques, we are all using either plain scissors or unipolar or bipolar cautery. It is best to use the the scissors, because the injury to the endometrium is the least. But the evidence says that there is insufficient papers at present to recommend a specific method for hysteroscopic septal resection. Another question which comes to our mind is, how much time should we tell the patient not to conceive after a septal resection? So evidence shows that it is about 2 months before which the patient or the couple should start to conceive, because there have been studies where multiple biopsies have been taken prospectively, and it was seen that by 2 months, the cytokines and the prostaglandins, the TNF alpha, all those things had normalized by 2 months after doing the septal resection. There is insufficient evidence. Some people say that before doing septal resection, you can give danazol or GnRH agonist so that the thinning of the endometrium is there, so that the blood loss will be less. So they say that there is not sufficient evidence to recommend this. And they also say that there is insufficient evidence to recommend for or against adhesions to prevent reformation of adhesions. But I think most of us are giving, either they are putting a pediatric Foley's, which is dilated, or we give estradiol. I personally give estradiol valerate 2 milligram BD or TDS and continue it for some time before I tell the patients to conceive. And also I do a ultrasound, 3D ultrasound, to check whether the septum or the fibroid has been completely, removed, and what is the condition of the endometrium. Another thing is that if the woman has had a second trimester pregnancy loss, they recommend the suspected cervical weakness should be offered a serial cervical sonographic surveillance. This should be done right at the time of NT&V scan between 11 to 13 weeks, and it should be serially followed. And if we find that the cervical length is less than 2.5 centimeters or the os is dilated, then we can go for cervical cerclage. And other papers show that progestogen can also be helpful. Now, coming to a very, very important cause, and this is the most treatable cause of RPL. This is APLA, the antiphospholipid antibody syndrome. This is the only proven thrombophilia which is associated with poor pregnancy outcome. Just mark it that it is present in nearly 5 to 15% of women who are coming with RPL, as compared to only 2 to 5% in the normal unselected population. So how to diagnose? The diagnostic criteria, we have these three tests. The lupase anticoagulant, this could be present or absent. And for anticardiolipin antibodies, IgG, IgM, and for beta-2 glycoprotein antibodies, we can do the titers. And the titers have to be repeated again, because a low or a mid-level can be positive due to number of false positive causes, and viral infections is the most important. So once it comes positive, there is no need to start the woman on low molecular weight heparin, that is enoxaparin or aspirin. We should get it repeated and then only give a counseling or start the treatment for the patient. Lac is the most specific of all, and if there is lac positivity and all three are present, then it is the worst prognosis. So how do you diagnose? It is the Sydney revision of the Sapporo criteria 2006, and we define that if one clinical and one lab criteria is present, then we say that the woman is suffering from APLA syndrome. So the clinical criteria includes vascular thrombosis, could be previous history, arterial or venous, pregnancy, morbidity. If she has had one or more deaths of babies more than 10 weeks, fetus more than 10 weeks, one or more premature birth at less than 34 weeks due to severe preeclampsia, FGR, or 3 or more abortions less than 10 weeks, and other causes have been ruled out, then we say that this single clinical criteria has been fulfilled. For the lab criteria, we have already discussed this. And again, I would like to reiterate that positive tests should be repeated at least 12 weeks apart, and high titer is regarded as 40 GPL or MPL. That is more than 99th percentile. Patients with APLA, even if they continue their pregnancy, we know that they are more prone to develop preterm labor, premature rupture of membranes, fetal growth retardation because of placental insufficiency, preeclampsia, eclampsia, and placental abruption. So the Green Top Guidelines 2015 by RCOG say, when should we start the management? So we should start it as soon as the diagnosis is made, before if the patient has had a previous morbidity associated with thrombosis, we have to start the low dose aspirin in the preconception period. And as soon as the cardiac activity comes out to be positive in the antenatal period, we need to start her on enoxaparin, which is 40 or 60 units, depending on the weight of the patient. And if she has a previous history of thrombosis, then heparin and low-dose aspirin should be started in the preconception period itself. And then during pregnancy, it has to be escalated. The dose needs to be modified, and it is given at 1 milligram per kg body weight. So both these things need to be continued till 36 weeks or 4 weeks before the EDT, and heparin should be continued till the patient goes into spontaneous labor or 1 day before induction or cesarean is planned. Sorry. And again, these things need to be continued in the postpartum period. Genetic causes I will not be taking in detail because we have another speaker who is going to deliberate on this. And the benefit of doing genetic causes is because the patient, the couple wants to know what is the reason. क्या उनकी कोई गलती है जिससे उनको बार बार pregnancy loss ho raha hai. So to give them a reason, it's a good idea. After the second miscarriage, you can do a chromosomal analysis of the POCs. So what are the techniques which can be done? Karyotype, FISH. The best one is comparative genomic hybridization or CGH microarray, because in this the contamination with the mother's blood is less, and the culture which is not growing generally in karyotype, that problem is also gone. And also we have next generation sequencing, which can be done. So the HRA guidelines say that genetic analysis of pregnancy tissue is not routinely recommended, but can be done for exploratory purposes. And the best technique is CGH array, microarray. Parental karyotyping should be done should be carried out after individual assessment of risk for diagnostic and exploratory problems. All couples who are found to be having abnormal fetal or parental karyotypes should undergo genetic counseling, and they should be told about the options which are available. So the options which are available are either they can be counseled, because they can even have a natural pregnancy with or without prenatal diagnosis, because the chances of recurrence are not so high, or they can go with for IVF with PGT-SR involving the geneticist, or a donor gamete can be taken if the father is having reciprocal translocation or Robertsonian translocation, then or adoption can be told. So now coming to the biggest chunk, the unexplained RPL. The most important thing, which whatever the guidelines may be saying, we are all using. Sometimes I see prescriptions in which 2 to 3 types of progestogens are giving. So let us see what is the fundamental, what is the rationale of using progestogens. It has immunomodulatory properties by increasing the TH2, which is a favorable shift. And also it modulates chemokines and it inhibits rejection and protects conceptus. And also it is a uterine relaxant. So these are the two important properties because of which we are giving progestogen treatment. So the European Progestin Club says that progestin treatment should be given for RPL patients. Foxy recommends oral dydrogesterone 10 milligram BD till 20 weeks of gestation. So there is a controversy. Some people like to give till 12 weeks, which is reasonable because the placenta starts forming and performing after that. And some studies have shown that the placenta is not very well taken. So it may be continued till 20 weeks. The Ismail study, this is a very well-known landmark clinical trial. They continue till 28 weeks. So it varies from doctor to doctor. Vaginal micronized progestogen is given in the dose of 400 milligram per day vaginally till 20 weeks. So coming to the types of progesterone therapy, we have the micronized progesterone, which is the natural progesterone. It can be given by vaginal route, capsule or gel. 200 to 400, 400 generally is used. The good things are that it has a local absorption, very few side effects because the first pass metabolism is passed. But the problem is our Indian patients are not very happy in putting anything in the vagina. It causes irritation and discharge. So it is also widely used in IVF and RPL. It has been recommended in the PROMISE and the PRISM trials. Dydrogesterone, we know all have been using. It is a synthetic oral progestogen. Dose is 10 to 20 milligram BD or TDS. Easily tolerated because it is oral use, but it has a slightly lower bioavailability. However, it has an emerging role in RPL and also in luteal phase support, and it has been proven in the espresso trial. So these are the important trials which have been done and which have recommended these. IM progestogen in oil, 50 to 100 milligram IM injection, generally used in IVF. Subcutaneous progestogen aquasustain is now available. It is saline based, not oil. So subcutaneous injection 25 milligram can be given. It is very less painful and it is an alternative in RPL and IVF. Oral micronized progestogen is also available It is convenient to take 200 to 300 milligram per day, 2 to 3 times, but it has a very poor bioavailability and sedation is common. It is much less effective as compared to the other routes. So these are the trials, the PROMISE trial, PRISM trial, Cochrane review, Espresso, Lotus 1 and Lotus 2, which are already available. So at the end, therapeutic interventions for unexplained RPL, what is not recommended is glucocorticoids, heparin and low dose aspirin. I do not agree with this because many times when these three investigations, the lupus anticoagulant syndrome comes negative, then also because we are not able to test for other tests, protein C, protein S, we are admitting the patients as soon as the cardiac activity is established and we have documented it, and we keep the patients. Our patients are generally not affording types, so we keep them admitted, and every day we give them enoxaparin injections till the time they deliver. And I have seen lots of patients continuing their pregnancy, and I would like to ask the chairperson to share their experience after the talk is over. Low dose folic acid is definitely recommended. Vaginal progestogens, they say, may improve live birth in RPL. Again, they say that insufficient evidence to use intralipid therapy, GCSF, endometrial scratching, multivitamin supplement can be taken, vitamin D can be taken. And now coming to the last of my slides, the new thing is that female reproductive microbiota has been associated with recurrent pregnancy loss. Earlier, we used to hear about gut microbiota. Now we realize that microbiota is present in the female reproductive tract also. And it has been seen that dysbiotic, there are a number of studies which have shown that altered or dysbiotic endometrial microbiota may be a novel risk factor for RPL, a condition which used to be labeled as unexplained earlier. And this altered microbiota gives rise to chronic endometritis. And the prevalence is 19% in general population, and it is very high. This chronic endometritis is very high in infertile patients and RPL patients. Most of these patients, either they are not having any symptoms or they present with dyspareunia, pelvic pain, vaginal discharge, abnormal vaginal bleeding, infertility, RIF, RPL. So we should be knowing that this entity also exists. And what happens is that causes this chronic endometritis causes edema, dissociated maturation of cells of the stroma and epithelium, and plasma cell infiltrates, which will cause the implantation to not occur properly. And the organisms which have been implicated are Enterococcus, E. coli, same that we have seen in the preterm labor or PROM. All those are same. So how to diagnose? When doing hysteroscopy, when we see focal or diffuse endometrial hyperemia or micropolyps, these small micropolyps less than 1 millimeter, and mucosal edema, then we can say that this woman may be having chronic endometritis. Microbial culture can identify organisms. We are generally, what we can do is plasma cell can be seen, or immunochemistry CD138 cell marker can also be sent. Next generation sequencing is also being used for this. So this thing can be also identified by hysteroscopy, as I've already said, and we can do this methylene blue can be pushed, and we can mark the areas which are where the stain is being taken. Presently, chronic endometritis and vaginal infection seems to be routinely investigated by most of us, and the treatment kya dena hai? Doxymetro, which we have been giving for years and years, and the new thing is that we can also give probiotics. Vaginal probiotics have been really helpful. Moderate vaginal microbiota modulation was achieved by giving this, and it may have a bearing on RPL. So to summarize, RPL is, according to the HRA guidelines, more than 2 abortions, and the recommended tests are antiphospholipid antibody test, thyroid antibodies, and uterine abnormality detection by 2D, 3D ultrasounds. We have discussed all these treatments. The tests which can be considered for knowing what is the cause are the genetic test, genetic counseling and information on PGT to be given. Immunologic, no treatment specifically is available. IgG can be given. That people are trying, but insufficient evidence till date. Sperm DNA fragmentation tests ask for lifestyle advice and stop smoking, alcohol, exercise, reduce weight. Screen for hereditary thrombophilias only to know what is the cause, and if no other cause has been found. And the tests which are not recommended are immunological tests, metabolic hormonal tests, and also torch test. Torch test, I see lots of prescriptions coming to our OPD where torch test has been done in all patients, antenatal patients, I'm surprised, infertility patients and RPL patients. And as Dr. Goyal has already emphasized, there is no better thing than tender loving care, lifestyle advice, and prophylactic vitamin D, which can be done easily. So,
Thank you. Thank you.
reassurance, tender loving care, good lifestyle. I think these are the things which are essential for all of the chronic diseases. So I thank you all for a patient hearing.
Thank you. Thank you very much.
Thank you, sir.
Thank you, Dr. Paiki. You have really told everything about RPL. But few points I also disagree from that point that submucous fibroids and endometrial polyps should not be removed. I think in the RPL cases that should be removed. That should be that was written in guideline.
Yeah. I also said the same thing,
Yes,
and
you
I
also
want sir's opinion,
yes,
Dr.
I am
Latika,
also,
Dr.
I am
Nidula,
also of the same opinion.
because this is not easy to
We
digest.
agree
If
with
you
that.
have,
Though
yeah,
it
Yes,
is
we also agree
not
with
written
you.
over there, but it should be removed.
yeah.
RPL means she's having it again and again. So when we have an obvious cause in front of us, then that needs to be taken care.
That is already in cavity. That should be removed.
And
We
excuse me, I want to say something.
Yes,
For
Dr. Latika.
removing endometrial polyp, because the endometrial polyp usually they don't cause recurrent pregnancy losses. Submucous fibroid, I agree, should be removed, but about polyp, we should exclude other causes also before removing the endometrial polyp. Once the pregnancy occurs, usually the endometrial polyp is not the reason for recurrent pregnancy loss.
I agree with
And
you, Dr. Latika. I think it is always a good idea during stimulation. There are, proliferative polyps also.
Yes.
So after she has her menstruation, we should definitely do an ultrasound and see how big is the polyp. Is it
Yes.
big enough? Because the idea is, the rationale is, if it is big enough, then it can increase the prostaglandins and cytokines alteration in the endometrium, and then it can increase the contractility. So that is the idea. And of course, we have to rule out all other causes. जो
Yeah.
treatable causes
If
है,
it is
easy
less
to
than 1
treat है,
centimeter, usually it is not required
no
to
need.
remove it.
Less than
Yeah.
1 centimeter, I
We
said
don't
it
have to.
could be because of chronic endometritis.
Yeah.
It is a good
Thank
idea
you.
to give probiotics or antibiotics, doxymetro. हमारा
This is my
जिंदाबाद.
practical
So,
experience. I have seen many of the patients.
absolutely, I
We do
agree.
IVF and we don't have any problem even with the presence of endometrial polyp.
I agree. Less than 1 centimeters, no need to
Yeah.
operate.
And I am also prescribing that IM immunoglobulin in unexplained RPL cases.
Yes, Dr. Pragati, I think sometimes if patients are affording, it's a good idea because nothing else is working, and sometimes this works. Although the papers are not having, actually the problem is that we are not publishing so many papers. So
Yes,
if
yes.
the evidence will be built only on
Yes,
papers,
there,
so
yes,
I think that's a good.
there are some studies.
Ji.
Let us
Uh,
now introduce
I
our
want to
next.
say one thing more. Sorry to disturb. In one of my patients, there were 6 recurrent pregnancy losses, and then I changed the gametes. I took the embryo from outside with the consent
Yeah.
of the patient. The patient had the full-term pregnancy. It
Bilkul.
worked
Donor oocytes was one of the options that
ultimately.
we could use.
Excuse me, should progesterone be prescribed as empirical therapy in recurrent pregnancy loss?
So
Yes.
as I showed in the in my in my presentation, the Foxy guidelines say, the HRA guidelines also say it has some role. Cochrane review papers also say, and in all our experience, I think the IVF specialists are here, and we have all seen in our experience that we are giving progestogens, and it does help. The rationale is there. Of course, we should not give 2 or 3, because the chances of the number of patients coming with IHCP, cholestasis of pregnancy, are increasing, and there should be some rationale. Kitna dena hai, kaun sa dena hai? It's not that you give all the progestogens, you start giving estradiol also, you give enoxaparin, aspirin, sara cocktail nahi dena hai, but we should use it judiciously. It does help. I've shown those papers na, मैंने वो detail नहीं दिखाया. All those studies, PRISM trial, PROMISE trials, or Cochrane reviews, all those I had shown in that table. They all say there is some evidence, especially of dihydrogesterone and vaginal progestogen and intramuscular progestogen.
Madam, you said one word, chromohysteroscopy. What is that?
Chromohysteroscopy means that we are staining. जैसे हम chromoperturbation में we are pushing in the methylene blue dye ना. So when you are putting that dye, you will see some areas which have taken up the stain and some areas which have not taken up. That is known as chromohysteroscopy. So in
that is
that
one
you
of
can identify which is having inflammation and edema. So that is a good area. From there you can take a biopsy and send it for that CD for that count.
Very
And plasma
interesting.
cell.
one
This
very
going
good
on.
point you have raised, madam, that we are not publishing our experience, and all esteemed people are sitting over here. So publication from our side is must to get some evidence. Yes.
So, Dr. Picky, in chromohysteroscopy, we are picking up which area? The one which is picking up the dye, or?
Yeah.
Okay.
Very interesting discussion going on, but I think so I would interrupt. Questions can be put on chat box. Ma'am, introduce
Thank you, Dr. Rich.
Thank you, ma'am.
Thank you all the chairpersons. Thank you very much.
Dr. Pragati or Dr. Godavari, madam, please.
Good evening, everyone.
Just a minute.
Dr. Picky, it was an outstanding deliberation.
Yes, now you may continue.
It was an outstanding deliberation that you have explained everything very nicely. But that part was, I also want to know about the dye that is used.
Same dye, madam, that we are using from chromoperturbation na?
Methylene blue dye.
Same dye, blue dye, the methylene blue dye. Same dye can be used. And we, आपने भी देखा होगा ना, if we do hysteroscopy later on, after doing chromoperturbation, we will see some areas which are blue and some have not taken up. So that will distinguish.
The area which are not taken up, from there we have to take the biopsy.
Areas which are not taken up.
Okay, thank you very much.
Thank you.
To introduce our next speaker, please.
Dr. Pragati,
ma'am.
Yes. Okay. Our next speaker is Dr. Deepali Saxena. She is MS.
Deepti Saxena.
Deepti Saxena.
Deepti Saxena.
Okay. She is MS from SN Medical College, Agra, and DM Medical Genetics from SGPGI, Lucknow. And she is at present additional professor, Department of Medical Genetics, SGPGI, Lucknow. Her areas of interest are skeletal dysplasia, prenatal diagnosis of fetal malformations, reproductive genetics. Her various publications are various research publications in national and international journals, and the research interest research projects on craniovertebral junction anomalies, fetal malformation, and dysmorphology. The stage is yours, Dr. Deepti. You can.
Thank you for the kind introduction. And first of all, I would like to thank Dr. Ruchika Goyal ma'am, Dr. Shashibala ma'am, and Dr. J.K. Goyal sir. Also the esteemed office bearers of IFS UP West, Bareilly of Gynecology Society, for giving me this opportunity to present this topic in front. I will share my screen.
Your voice is slightly slow. Not very well audible.
Okay. So is my screen visible, ma'am?
Yes, your screen is visible.
Okay. So is my voice clear now, ma'am?
Slightly
Uh,
less clear.
I will try to speak louder.
Okay, okay.
Is it clear now, ma'am?
Yes, yes. Better.
Okay. So the topic for today is first trimester aneuploidy screening and inverted pyramid of care. So as we know that initially the level of care increases as the gestational age of the pregnant lady increases. But now with the advent of newer investigations, in the first trimester only we can diagnose many fetal problems also and pregnancy related complications also. So what is the purpose of prenatal testing? The purpose is to diagnose diseases in a fetal embryo when it is born. It can be done by prenatal screening as well as testing. So first step of any prenatal screening is a complete family history. So we should take the 3-generation pedigree, where we take history of 3 generations of the family. We take maternal age. We should look whether there is a family history of developmental delay or any muscular dystrophy or any hematological disorder, or there is any history of recurrent miscarriage or stillbirth, or if there is history of any congenital malformations in previous pregnancy. Also, we can offer carrier status for common genetic conditions such as thalassemia and spinal muscular atrophy. For the current pregnancy, we should look for whether there is history of any drug intake, infection, radiation, or any chronic maternal disorders, or there is any research incompatibility or any structural malformation or soft marker on ultrasound, or any serum aneuploidy screening test has been done. So coming to the topic for screening for Down syndrome, as we know that there are 3 to 5% of pregnancies which are complicated by birth defects or genetic disorders. Chromosomal abnormalities can be seen in around 1 in 250 births, which include aneuploidy, translocations, deletion, and duplication. But the most common is trisomy 21, which can be seen in 1 per 800 live births. Sex chromosome aneuploidies are less common, and trisomy 13 and 18 are rare. So Down syndrome is the single most common cause of intellectual disability. So as we all know that the incidence of Down syndrome increases as the maternal age increases, and it decreases as the gestational age increases, because some of the Down syndrome fetuses are spontaneously aborted in the first trimester of pregnancy. So what is the purpose of screening? It is to identify the females at high risk. It is not for all genetic disorders, and it should be offered to all females, but it should not be ordered. If the screening test is positive, termination of pregnancy should not be done, because there are chances of false positive screening test. So what should we do? If there is a positive screening test, then we have to do confirmatory test by chorionic villus sampling or amniocentesis. We should explain the cost of the procedure. It is a minor procedure and there is a minimal pain associated with it. We should explain the risk of pregnancy loss, which is around 1 to 500 in 500. We should explain that if any chromosomal abnormality is detected, then there is no intrauterine treatment which is available. So the female may have to undergo termination of pregnancy in case she doesn't want to have a child with chromosomal abnormality. So in 2007, ACOG has eliminated the age cutoff and said that there is a choice between screening and invasive testing at all gestational age, at all women, at all age. So initially we used to offer invasive testing above the age 35 and screening test below age 35. But if a female comes at age 25 years and asks for invasive testing because she is too anxious and does not want to go for screening test, we can do invasive testing at age 25 also. So the message is that screening tests do not diagnose a problem. They only signal that further testing should be done. So this is a graph that comes in the screening test report. And this is the confirmatory test report where we can see that there are 3 chromosome 21, which is suggestive of trisomy 21. And this is a baby with Down syndrome. So there are typical facial features from which diagnosis can be done by facial gestal. So what are the options for prenatal screening? We can look for some serum markers. There are some ultrasound markers. We can also combine these markers, and also there is a cell-free fetal DNA testing, which is known as NIPS. So in last 25 years, the screening has evolved from maternal age with the detection rate of only 30%, with inclusion of serum markers such as PAPI and serum-free beta SCG, with increase in detection rate to 60 to 70%, and then inclusion of NT with increase in detection rate to further 85 to 95%. And with the advent of cell-free DNA testing, the detection rate is now 99%. So what are the advantages of first trimester aneuploidy screening? It offers early diagnosis. It can be done between 11 weeks to 13 weeks, 5 days of gestation. The detection rate is higher, and it can detect around 90% of those with trisomy 21 with a false positive rate of 5%. The disadvantage is that it does not include AFP, and identification of abnormal pregnancies that are anyways going to miscarriage may give undue anxiety to the couple. There are some practical considerations because there are some strict measurement criteria for the ultrasound markers. And if we diagnose any high-risk screening test in the first trimester, then we need to have expertise for chorionic villus sampling. So what are the factors which are important in the calculation of risk when we are doing the first trimester screening? We should look for the maternal age. What is the gestational age of the fetus? What is the maternal weight, race, whether she is smoking or has diabetes? What are the number of fetuses that are present? Whether the pregnancy is IVF conceived, and if IVF conceived, whether the donor egg is used or whether self egg has been used. In case of donor egg pregnancy, the age of the donor should be mentioned while calculating the risk. So we are measuring PAPI and 3-beta SCG. So PAPI can also be used as a marker for impaired placental development. And if there is low PAPI, it is also a risk factor for pregnancy complications such as preeclampsia, IUGR, and preterm delivery.
Dr. Deepti,
Yes, ma'am.
Dr. Deepti, sorry to interrupt you. Your voice is not clear. Can you make it a little bit clearer?
Ma'am.
Your voice is not clear, Doctor.
Okay, ma'am.
Slides are visible, that is okay.
Are my slides visible, ma'am?
Yes, your slides are visible.
Okay.
No problem.
Voice is
Only
not.
voice is slightly less clear.
Okay, ma'am.
But it's okay.
Okay, ma'am. I try to speak louder, ma'am, because maybe some network issue is there.
It's okay.
Yeah. It's okay.
So this is a sample report of double marker test where we have mentioned the age of the mother, the gestational age of the fetus, the number of fetus, weight of the mother, and whether there is a IVF pregnancy or not. And we have measured the PAPI and free beta SCG. And then this all values are compared, and then we get a overall risk. So in this patient, the trisomy 21 risk is 1 in 99. So this is a high risk as the cutoff is 1 in 270. And the risk for trisomy 1318 is 1 in 499, which is a low risk. So if the patient has done the combined first trimester screen, means screening using the serum markers, PAP, beta, SIG, and combining anti-value, the detection rate is around 90%. So again, they have come and the second trimester and they want to do a repeat second trimester serum screen. So should we do that? So the recommendation is that the false positive rate of screening is increased when we are doing multiple screening tests, and this should not be done. We should stick to the result of a screening test that we have done, and repeating the test will not nullify the previous risk. So repeat test in the second trimester is done only when we are doing the testing as a part of integrated stepwise sequential or contingency screening. So what are these integrated sequential contingent screening? In the integrated screening, we are taking sample in the first trimester and again in the second trimester, and the risk is reported as a single risk. In this case, the detection rate is around 94 to 96%. In case of sequential, the first and second trimester results are reported independently. Suppose in the first trimester, the risk is high, then invasive testing is offered, and the low risk persons, they are again taking sample and the second trimester, and the results are combined, and then a final risk is estimated. In case of contingent screening, first trimester results are used to triage the patients into 3 categories. In low risk, there is no need of any further testing. In the high risk, invasive test is recommended, and in intermediate risk, we either do a second trimester test by quadruple testing, or we do a cell-free DNA testing and further refine the risk. Coming to the ultrasound markers, ma'am, is my voice clear now?
Yes,
Yes.
So coming to ultrasound markers, so there are sonographic findings in fetuses with Down syndrome. So sometimes we can have structural abnormalities such as duodenal atresia, and sometimes there are non-structural abnormalities or soft markers. So these soft markers are non-specific markers. They are often transient, and they disappear as the gestational age increases. They are not a pathology themselves, and they are used to adjust the risk for common aneuploidies. They are seen in normal fetuses also, and if they are seen, there is a slightly increased risk in fetuses with chromosomal abnormalities. So coming to first trimester markers, the most important marker is nuchal translucency. So this is a subcutaneous fluid-filled space between the back of the spine and the skin in the fetal neck. So for this measurement of nuchal translucency, the CRL should lie between 45 to 84 millimeter. That corresponds to gestational age of 11 weeks to 13 weeks, 6 days. The fetus should be in the mid-sagittal position, and the magnification should be such that the head and the upper part of thorax occupies most of the screen. The fetus should be in neutral position, that is, it should not be in hyperextension or hyperflexion, and the caliper should be placed on the skin. It should be on the margin. We should take at least 3 measurements, and the largest measurement should be used for the risk assessment. So if there is increased NT, we should do further invasive testing and not directly go for termination of pregnancy. If fetal karyotype is normal, there is residual risk of certain genetic syndromes such as Noonan syndrome and congenital heart defect or renal anomaly. For this, we should further do malformation scan and fetal echo at 20 to 22 weeks. If these are normal, then there are very high chances of satisfactory outcome. So there are charts available, and when the measurement of nuchal translucency is more than 95th centile for the CRL of the fetus, then we take it as an increased nuchal translucency. Coming to next marker is nasal bone. So for nasal bone, we have to look whether it is absent or present. Again, the limit of gestation CRL is 45 to 84 millimeter. The fetus should be in mid-sagittal view, and the fetus should be facing towards the transducer. The head and upper thorax should occupy most of the screen, and the image that we see is 2 echogylnic lines. So this echogenic line represent the nasal tip, and these are the two lines that represent the nasal skin and the nasal bone. So this is also known as the equal sign. In case when there is a trisomy 21, this equal sign is not seen, which is suggestive of absent nasal bone. Another marker is ductus venosus Doppler. So we see the ductus venosus waveform on pulse Doppler. Normally, there is a forward flow throughout the cycle, such as in this flow. So in this, we place the pulse Doppler gate at the position of the ductus venosus, and we see the waveform. So this is the position of the A wave. It is formed due to atrial contraction. So normally there is a flow at this point, but if there is a chromosomal abnormality, we may see a wave reversal in fetuses with trisomy 21. So here you can see that the flow is reversed. So this is known as A wave reversal. So, so it may be seen in fetuses with chromosomal abnormality or in cases where there is any congenital heart defect. Next marker is tricuspid regurgitation. In this case also, we focus in the four-chamber view of the fetus. Then we place the pulse wave Doppler across the tricuspid valve, and we look for the tricuspid regurgitation. So this is a normal flow where there is there is no regurgitation at this point. This is the duration of the ventricular systole where there is no flow. But in case of tricuspid regurgitation, when there is ventricular systole, there is reverse flow in the opposite direction. So this is seen in cases with chromosomal abnormalities and also in cases with cardiac defects. So after doing all this serum markers as well as the ultrasound markers, some of the trisomy 21 pregnancies can remain in the low risk group because each of these methods is a screening test and not a confirmatory test. So this should be explained whenever we are doing ultrasound or serum testing. So pre-test counseling is required for all these. Now, the next is the non-invasive prenatal screening, that is the NIPS test. So, to increase the detection rate further, we are now doing non-invasive prenatal screening test. It is in non-invasive testing, and it was first seen in 1997 that there is cell-free fetal DNA in blood of pregnant female. And first application of this cell-free DNA was non-invasive diagnosis of fetal Rh typing. And in 2011, NIPT was commercially available for the first time. ACOG has said in a recommendation in 2020 that cell-free DNA testing can be used in all patients regardless of the maternal age or baseline risk. So what is the cell-free DNA? As you can see that this is the maternal plasma. So it has DNA both from the maternal blood cells and DNA coming from the placenta. So this maternal plasma now contains DNA, fetal DNA as well as the maternal DNA. But the origin of the fetal DNA is not directly from the fetus, it is from the placenta. So most of the cell-free DNA in maternal serum is of maternal origin, and there is a small amount of fetal DNA which is known as fetal fraction. The amount of fetal DNA depends on the gestational age of the fetus, and it has been seen to be associated with maternal age. So as the maternal weight increases, the percentage of fetal DNA decreases. Also in case of chromosomal abnormalities like trisomy 13 and 18, the fetal DNA fraction is low, whereas it is increased in case of trisomy 21. So the reporting time for NIPS is 7 to 10 days. Repeat sampling can be required in around 2 to 4% of cases. If NIPS shows high risk, then we should do invasive testing for confirmation. But if there is a structural abnormality on ultrasound, we should do invasive testing instead of NIPS. So in case of increased NT or any other structural malformation, we should not do NIPT, we should always do invasive testing. So as you can see that this test is highly specific for all the common chromosomal abnormalities. The specificity is up to 99%. So advantage is, again, it can be done as early as 10 weeks of gestation. There is high sensitivity and specificity. The report is interpreted very easily as the report comes low risk or high risk. The negative predictive value is also very high, and it has led to decrease in the number of false positive in screening test. Limitations include it is a costly test. It is again a screening test and not a confirmatory test. It will not look for all the chromosomal abnormalities. It will look for trisomy 13, 18, 21 and sex chromosomal aneuploidies. It cannot identify polyploidy. Also, it will not assess the fetal abnormalities such as neural tube defects, which can be assessed in serum testing by quadruple testing. So we need to either do a detailed ultrasound for neural tube defect, or we need to separately test for serum alpha-fetoprotein. It does not substitute the need of ultrasound for fetal defects and for other complications of pregnancy. Some cases there can be false positive NIPT, means NIPT is positive, but still the baby is having normal chromosomes. So the various reasons include maternal copy number variant, there can be maternal mosaicism, there can be maternal malignancy, or in case of vanishing twin. Coming to these situations one by one. So as you can see, the situation is confined placental mosaicism. So the baby is normal, but some of the placental cells are having chromosomal abnormality. So as we earlier came to know that fetal DNA is coming from the placenta. So sometimes if the fetal placental DNA is having some abnormalities, it will give rise to false positive NIPT result. If there is a maternal chromosomal abnormality, like in case of Mosaic-Turner syndrome, so the lady may be in phenotype normal, the pregnancy may be conceived normally, but there may be a small number of cells with a chromosomal abnormality concerning the X chromosome. So it will lead to false positive NIPT. In case of vanishing twin, suppose there was a spontaneous abortion of a twin, co-twin at early gestation, but the fetal DNA will remain in circulation. So that will confound the result of NIPT. So it has been seen that after the fetal DNA of the vanishing twin will remain in circulation up to 8 weeks after demise. So if there is a history of death of the co-twin, then NIPT should be done after 8 weeks of confirmation of absent cardiac activity. In case of multiple pregnancy, NIPT should be done, but the methodology should be, the NIPT should be done using SNP method. The sex chromosomal abnormalities can also be picked up, but it can be false positive in case of mosaic chromosomal abnormalities. Coming to rare autosomal trisomies, now NIPT has been extended to other chromosomes besides chromosome 13, 18, and 21. But for these, the positive predictive value is not so high. So in these cases, if we are going for screening for rare autosomal aneuploidies, then instead of chorionic villus sampling, we should do amniocentesis for confirmation, because sometimes the chromosomal abnormality may be confined to the placenta and it is not present in the fetus. So this should be kept in mind when we are offering NIPT for other autosomes. Also, recently NIPT has been extended to include microdeletion and duplication, such as DJOS syndrome and other rare microdeletion syndromes. But for these also, the positive predictive value is very low. So it should be done in case of known syndromes with a well-defined phenotype and should not be offered to all. So the counseling in these cases is very challenging, as in case of NIPT, we are looking at a small number of chromosomes, whereas if we are doing invasive testing, then we are looking at full chromosomal complement. If we are doing microarray, each high-risk woman need to decide between whether she opts for invasive testing or NIPS. 20% of females, it has been seen that they will not do any testing, whether screening test, even if we are removing the financial barriers. So future prospects of using this NIPT technique, we can detect aneuploidy using whole genome sequencing from a single RBC taken from the maternal blood. So these are yet to be in the research basis. So the take-home message from my side is that the all pregnant females have three options. Either they can go for screening, or they can go for direct diagnostic testing, or they can go for no screening or testing. It is a personal decision and there is no wrong answer. They can choose invasive test at any maternal age. Parallel screening with multiple methodologies is not cost effective and should not be performed. Because we are seeing patients, they are having a double marker report, and then in second trimester, they are having a quadruple test report. So it should not be done. Whenever there is a double marker test that has been done and is low risk, there is no role for repeating a test in the second trimester. Most costly test does not guarantee an unaffected baby. And if a screening test is positive, a diagnostic test is recommended. Because this is also a common scenario that a patient come and they say that in last pregnancy, my quadruple test was positive and the straight away termination was done. So it should not be done because there are high chances that quadruple test is false positive and the fetus is normal. So we should confirm by diagnostic testing and then we should take any irreversible decision. So thank you all for the patient listening and I hope I have not confused. So thank you all.
Thank you, Dr. Deepthi. You have made such an elaborate or topic, and you have made everything clear. And that is the most important point is that we cannot compel any patient. That is up to her whether to adopt any screening test or not.
Yes, ma'am.
But ideally we should write definitely on the prescription that
Yes.
patient is not ready.
Yes, ma'am.
And sometimes I have seen that in double marker the test was negative and in quadruple the test was positive. That is really very confusing.
Yes, ma'am. So double marker is negative and the patient is anxious, or if we find some soft marker on ultrasound on second trimester, like anomaly on CT scan, if there are soft markers, and the patient
Go
is
for
not,
NIPT.
we can go for NIPT because this is a
Yes.
with higher sensitivity. So we
Yes, ideally we should not prescribe quadruple.
yeah.
If double marker is already done, then we should not prescribe.
Ideally, we should not be doing if the first
Yes.
first trimester, if the dual marker is negative, then there is no need to
We
do
should-
quadruple marker, as very well highlighted by Dr. Deepthi.
Yes, yes.
And the second question is, can the NIPT replace dual marker and quadruple marker, Dr. Deepthi? If somebody is very anxious and they want to tell us the best test, doctor, so
Yes.
is it okay?
Yes, ma'am. We can do
Yes,
NIPT because
We
it
can
is
we can skip we can skip dual, we can skip quadruple in whichever time frame she has come to us, and we can get an NIPT done.
Yes, ma'am.
And what
Yes.
is the maximum period in which you allow the NIPT, till what time?
NIPT can be done at any time, ma'am. After 10 weeks, it can be done at any time. Because
Okay.
The
So
problem would arise, ma'am.
for the termination, if there is need.
Yeah.
Yes,
That would
yes.
be the
Mridula, nowadays now what happens ki if we are seeing patient of previous history of missed abortion or any congenital defects, if we are suspecting, so people they are advising NIPT at 10 weeks, 9 to 10 weeks, because
Yes.
it's easy to terminate pregnancy at that level.
And this is for thing, if the patients are coming late, they have missed their time for
Yes, yes.
dual marker, they have missed the
It's
time for
better
quadruple.
to NIPT.
And then we can at least advise them to get something done. Because I recently got a patient, she came to me for the first time at 22 weeks with nothing done on her. So this can be recommended, and as very rightly Dr. Deepthi said, that counseling forms a very integral part.
Yes.
So we need to counsel.
if in previous pregnancies anything has come positive, then also we should go for an IPT
No,
rather than
Yes.
the screening test.
no,
Exactly.
Somebody
And
has
I've seen many of our
cost of
colleagues,
NIPT.
many of our colleagues are getting done a dual marker and then again a quadruple marker. So very rightly pointed out by Dr.
Not
Deepti that
needed.
that is not needed if the dual marker is negative. It's low risk, not negative, but low risk.
one point I would like to say, like the earlier gestational age, so it is better to do first the NT scan, NT scan, because if there is any structural malformation that is detected at that time, and in the same period we can go for NIPT.
Yes, yes.
And also, if
That
there
you
is
very rightly pointed out that these dual marker, quadruple or NIPT, they do not replace our ultrasound, the anomaly scan first trimester and the TIFAs in the second trimester. They do not replace them. That have to be done. That is, we have to do them.
But NIPT also doesn't exclude all the chromosomal abnormalities.
yes, ma'am.
No,
So
it
if,
doesn't.
I
It's the
just-
similar.
if there is history of any congenital
Request,
malformation,
I
then-
request everyone, we have very nice panel to discuss and all
I
the
just-
questions would be answered there. And can we have your, this thing, please? Can we go for the panel discussion?
Dr.
Yes,
Deepti,
Thank you,
can you
Dr.
please
Deepti.
stop your
Many questions over there.
I just
They
wanted
all
to
will be
add one
answered.
thing.
Yes, ma'am,
Otherwise,
That
we were waiting
Yes,
to
I
Dr.
just
Rabri.
wanted to add one thing, that in the first trimester, dual marker are recommended routinely, na? We advise in all the patients, dual
All the
marker.
patients.
Dual marker is
Yes.
recommended, but if the patient is affording and NIPS is better test than dual marker.
Yes.
Because
and that they have come
No, no.
in that timeline also.
yes.
If they have crossed, like as Madam Radula has said, the patient has come at 20 weeks, then there is no point doing 12 marker.
Thank you,
But
Dr.
I think
Deepti.
the patient has come timely within 12 weeks and she doesn't have any history, previous history. Dual marker is enough, I
interesting
think.
brainstorming.
Dr. Ruchika Madam, can we start having this panel discussion? There is some issue in network, I think. Dr. Ruchika? Madam Neera? Madam Neera hai?
Yes, yes. Shashi, I'm here only.
Yes,
Yeah,
please.
yeah.
We can start now the panel discussion.
Yes, yes. Yes, yes, we can start.
So Dr. Preeti, Dr. Ayushi, you can invite the panelists, these things. You start.
Good evening, everyone. I'm welcoming all our experts for this panel and our panelists. I'm introducing Dr. Neera Agarwal. He is graduated and did have MBBS and PG from KGMC and chaired many sessions in state and national conference. And Dr. Latika Agarwal ma'am, she is very senior gynecologist and doing her private practice and self-owned startup test tube baby center Bareilly. And Dr. Namita Agarwal, she is a professor in Department of Obs and Gynae, SRMSI Bareilly, and she's lifetime member of IMA, Foxy. Dr. Anita Nath ma'am, she is director of Nath Hospital Bareilly. Dr. Yogita Nath ma'am, she's assistant professor and running IVF center in Royalton Medical College. Dr. Anita Bhagwani Jhabadia ma'am, she did her MBBS and the DNB and director of Adya Hospital and Fertility Center. And Dr. Ruchi Srivastava ma'am, she's the alumni of GSBM and doing her private practice. And Dr. Dipali Verma ma'am, She is a maternal and fetal medicine consultant and genetic clinic, ultrasound center, Dharmantri Super Specialist Hospital, Muradabad, Uttar Pradesh. She did her PDCC from SGPGI. Dr. Pallavi Bansal ma'am, graduate from KMC Mangalore and post-graduation from LHMC Delhi and did her senior residency from SRMS only. Dr. Shipra Gupta, she is assistant professor in the State Medical College, Firozabad. She did her MBBS, PG, SRC from SRMS only.
So we welcome all dear experts and panelists for the panel discussion today. A lot theory has been discussed and a lot of points have been cleared. So we would directly be moving on to the clinical case scenario.
Someone needs to introduce the moderators also.
Because of time,
Nobody has introduced the moderators. So I request the organizers to
Yes,
introduce.
yes. So we have two moderators of this beautiful panel session.
Ayushi, please show your, you are screen sharing, so please show your slide, CV slide, and Dr. Preeti's CV slide.
We do not have that.
So both of them is assistant professor in Department of Obstetrics and Gynecology. Dr. Preeti has done her PDCC AIMS Rishikesh, and Dr. Ayushi, most of you must be knowing her because she's personally meeting everyone in the Bareilly Obs-Gynae Society, and she's promoting a lot fetal medicine and really doing good work on improving the antenatal care. And she has many accolades in her credit, and she's a young dynamic faculty of our department. So I hand over the mic to Dr. Preeti and Dr. Ayushi to please conduct
Can we see the slide of Dr. Ayushi Shukla?
Ma'am, is it possible?
Yes, it is very much visible, and I can see that she has certificates from the Fetal Medicine Foundation, and she's doing great work here in Bareilly.
She is actually, ma'am, FNB fetal medicine, and she has joined us last year. And since then, she's with us and running independently, very beautifully, the fetal medicine clinic at IMS.
Yes, we are sending patients to her, and we are getting,
I am also sending her patients.
Yes.
Continuously.
And Dr. Preeti, she's, as I have told, she's assistant professor here.
Yes,
she's very hardworking and very good clinician. She has mastery in dealing critical care medicine, and she is she has special interest in fetal medicine. She is the co-moderator with Dr. Ayushi.
So congratulations, Dr. Ayushi and Dr. Preeti.
Thank you so much, ma'am. Thank you for the kind introduction. Because of time crunch, we will now be directly moving to discussion of certain case scenarios. I hope my screen is visible to everyone.
Yes, you are visible, Dr. Ayushi.
Thank you, ma'am. So we begin with Mrs. A, who is a 27-year-old P0A4, married for 6 years, non-consanguineous marriage. She has come to puberty in her interval period, not pregnant at the moment.
Your screen is not sharing your slide.
It shared.
To see the slides.
We can see.
Our slides are visible in the slides.
Dr.
We can see those slides.
We are able to see.
We are able to see, yes.
Yeah.
Yes, we are able to see. Continue. So the lady gives history of 4 miscarriages, all spontaneous conceptions with losses occurring early between 2 to 3 months of gestation itself. Ultrasound could be done in only one conception, which was suggestive of anembryonic pregnancy, what we commonly call as blighted ovum. The other 3 pregnancies were confirmed by a urine pregnancy test at home, and before she could reach to the doctor, she had bleeding. I would first request Namita ma'am, based on this history of 4 first trimester losses, only one being a documented ultrasound pregnancy, other 3 biochemical pregnancies, does Mrs. A fit into definition of RPL? If so, why?
Thank you, Ayushi. I hope I'm audible. Am I audible, Ayushi?
Yes, ma'am, you are audible. Please raise the volume. You are audible, but just raise the volume.
First of all, I would like to thank all the office bearers of IFS for putting up such a common, challenging clinical scenario for the panel discussion. Coming to your question, Ayushi, as we have just one documented pregnancy by ultrasound, all the other three have not been documented. According to ASRM, they want a documented consecutive 2 losses, which are documented either by HPE or ultrasound. So she doesn't fit into RPL according to ASRM, but ESHRE is comfortable with 2 losses which have been documented with just HCG levels. That is a urine pregnancy test or a serum HCG level.
Absolutely, ma'am. So biochemical pregnancies, what the recent guidelines say is that because their association is with increased risk of subsequent losses and there is a potential for shared underlying etiologies, many a times in clinical scenario, we do see women who may not have reported to the doctor because they have had bleeding and miscarriage earlier. But yes, consideration of biochemical losses should be there, and based on this criteria, Mrs. A does fit into the definition of recurrent pregnancy loss. Moving on, we have Mrs. B, who is a 38-year-old lady, Para 1 Live 1 A2, married in 2020 with a BMI of 34, known case of PCO. She has come to the interval period. Her obstetric history is as follows. First was in 2021 a missed miscarriage at 2.5 months of gestation, which was managed. Second, 2023 was a preterm section at 33 weeks. Growth restriction with Doppler changes in the baby. She has had history of early onset preeclampsia from 30 weeks of generation, birth 30 weeks of gestation, birth a baby boy of 1.2 kg who is now doing fine after an ICU stay of 15 days. Subsequently, in 2025, she planned her second, she was trying but could not conceive, so ovulation induction was done. She conceived but miscarried the pregnancy at around 2.5 months of gestation for the same. Ultrasound was done, which showed that a fetus with a CRL of 22 millimeters was documented, but there was no cardiac activity. So we have Mrs. B, who has one first trimester miscarriage, one preterm birth pertaining to preeclampsia of FGR, and one first trimester miscarriage. Anita ma'am, I would request you to please categorize Mrs. B into the category of RPL, either yes or no, and if yes, why?
Yeah, she fits into the category of RPL because she has 2 spontaneous abortions. So we can keep her in the category of recurrent pregnancy loss.
Absolutely, ma'am. And with the concept that consecutive losses have to occur is now being removed, and this has been recognized in the recent RCOG guidelines as well, which say that the incidence of certain diagnosis that is the cause of RPL may not appear to differ between women who have consecutive or non-consecutive losses. So Mrs. B also fits into the definition of RPL. Thank you, ma'am. Our third and last case scenario is Mrs. C. She is a 40-year-old lady, G2A1, been married for 10 years, is a known case of chronic hypertension, currently not on any medication. Her present conception was IVF, own gametes, came to the OPD with complaints of bleeding per vaginum at 16 weeks. Unfortunately, the scan at 16 weeks was missed miscarriage. In this pregnancy, she had NT scan done at around 13 weeks, which showed a structurally normal fetus, and the NIPT results were also normal. Prior to this present pregnancy, 6 years back, she had one more conception which was spontaneous, but unfortunately miscarried at 2.5 months of gestation and was surgically managed. So I would request Yogita ma'am to please classify Mrs. C. Will she subsequently fit into the definition of recurrent pregnancy loss because she just has one second trimester loss and prior was one miscarriage, first trimester loss?
Hi, good evening, everyone. Yes, I agree to this. And I think according to ESHRE guideline and RCOG also, if the miscarriage is first trimester or second trimester, if it's more than two and more than 2 comes into RPL.
Yes, Yogita ma'am, thank you so much. So we have these varied case scenarios wherein the concepts that we want to highlight for recurrent miscarriage or RPL is that As per all the guidelines now, the numbers have come down to 2. RCOG still sticks to 3 first trimester miscarriages, but now it states that any loss which is non-sporadic, that is, we suspect an underlying pathology. Like in Mrs. C, she had a normal NIPT, normal NT scan, first trimester screening. Post that, she went on to miscarry in second trimester. It is important that we start evaluation earlier. And the concept of consecutive losses has subsequently been disposed of with time. Moving on to our discussion, Anita ma'am, I would request you to address this problem that does gestational age at the time of miscarriage help us narrow down the causes for RPL?
Thank you, Dr. Ayushi. Good evening, everybody. The gestational age at the time of recurrent pregnancy loss or spontaneous abortion can provide clues about the cause. 70% are due to chromosomal abnormalities in the first 12 weeks. And hormonal causes are also usually infections, and endocrine causes such as diabetes and thyroid and luteal phase defects are all in first trimester. Causes which are common in second trimester are uterine abnormalities like endometrial polyps or fibroids or cervical insufficiency, thrombophilias, and defective placentation due to APLA. All these are usually second trimester losses.
Yes, ma'am, very well put. We do not have a hard and fast distinction. There can be overlap in causes, but yes, for the second trimester, as soon as we reach second trimester, the things that light up more in front of us would be any kind of uterine abnormality or cervical insufficiency, or anything which is related to defective placentation as well comes into our mind. Coming back to Mrs. B, Ruchi ma'am, what all are the risk factors we can identify based on the available history on our screen for Mrs. B to be predisposed to recurrent pregnancy loss?
With the history of Mrs. B, it seems that she is coming with ringing her bells with both of her hands. Like starting with her age, she is 38 years of age. More than 35 years age is a risk factor. Then she has a BMI of 34. Anywhere BMI less than 19 or more than 25 are more prone to for the abortions. Then she is a known case of PCOS. The PCOS, we all know, is a factor to be considered in cases of recurrent pregnancy losses. Then she has number of previous miscarriages also. This also leads to increased risk for this pregnancy. There is early onset PET in one of her pregnancy in which she has a viable baby, but there was PET. It is a risk factor that she may have antiphospholipid. We will have to investigate her for the antiphospholipid syndrome also. And in this pregnancy also, she has conceived on ovulation induction. Some studies show that even if the patient has conceived on ovulation induction, this it's in itself is a risk factor. Though some people differ, but there are theories that if the patient has conceived on ovulation induction, she is at a higher risk.
Absolutely, ma'am. Thank you for the detailed elaboration. This table is what is available from the recent RCOG guidelines, which highlight advancing maternal age to be the most important risk factor for recurrent pregnancy loss. That is, once a woman comes to us in OPD, this chart could be very much handy for us in counseling, as in a lady who is 40 years of age, has had previous 2 or 3 miscarriages, fits into definition of RPL. We know that her subsequent risk of miscarriage lands somewhere near 51%. That is roughly 1 in 2 that the lady might miscarry again. One more point that ma'am has highlighted here, that although the lady has had a live birth in her obstetrical history that is available, but this here we know that previous live birth has no association with subsequent miscarriage risk. Previously, were of the opinion that a live birth or a secondary RPL may not be that bad as is a primary one, but here we can see that previous live birth does not confer protection against subsequent miscarriage. I would request our expert Neera ma'am to kindly enlighten us on the art of history taking an examination, which is equally important before we move on to any blood or imaging related investigations.
Yes, Ayushi, it's very true. First thing is this, we have to take history in detail, as you know, because history only reveals so many things to us. Because which type of pregnancy loss? Sometimes at the first thing is the age factor, then we have to document the pregnancy itself, whether that pregnancy was documented by ultrasound or not. And sometimes patient says, yes, once ultrasound shows heartbeat, and then after 2 weeks heartbeat gone. So like that we have to take history in detail, so we can ask the patient, ask the investigations, because only by seeing one abortion, whether it was blighted, whether it was missed, or whether it was late first trimester or early second trimester, that also matters. So by history taking we can just do our investigations.
Absolutely, ma'am. The art of development lies in the fact that we stick to our basics and ground and then move on to the detailed investigations.
Yes,
And
yes.
thank you, ma'am. And HRA guidelines recently have also incorporated a model by Colte et al., which focus on the women's age and exact and complete pregnancy history to be the determinants of chances of having live birth in the next pregnancy. And a lot of tools are now being developed based on genetic models, biochemical models, machine learning, artificial intelligence. But yes, basic history taking and examination form the basis of all these models. Moving on, Dipali ma'am, Mrs. C's husband's age is 45 years currently. He is an occasional smoker and obese. Is there any role of evaluation of male partner as well in recurrent pregnancy loss?
Yeah, hello. Good evening, all respected seniors and organizers. Thank you for including me in such a fantastic academic event. In this case, her husband is 45 years age and occasional smoker and obese. So there are possibility of oxidative damage to sperms or free radicals is possibility. And in this case, with increasing paternal age, smoking, like you have written in slide also, smoking and alcohol consumption or body weight, there is increased risk of miscarriage, although it is not as much as maternal advanced age risk.
Yes, Dipali ma'am. So paternal age has now recently been incorporated as one of the additional factors that has to be assessed as a lifestyle parameter in the male partner.
Yes.
Pallavi ma'am, any particular investigation we can order for the male partner in cases of RPL?
Good evening, respected seniors and my dear colleagues and the organizers for giving me this opportunity to for this platform. Sperm, according to the SRE guidelines, the sperm parameters such as the morphology, total sperm motility, viability, hypoosmotic swellings, acrosomal status, and the nuclear chromatin condensations are decreased in the patients with the recurrent pregnancy losses. For such type of the patient, we can go for the DNA fragmentation index. The
Yes.
DNA fragmentation index is it is for the diagnostic. If it is very high, it shows it causes the recurrent pregnancy losses because it causes the aneuploidy of the embryo.
Yes, ma'am. So that is what the SRA also now says based on a trial that was recently done with high hyaluronic acid binding trial, which says now that for diagnostic purposes, earlier it was only in the context of research, but now for diagnostic purposes, DNA fragmentation can be offered as a modality for investigation in the male partner.
Excuse me, I want to
Yes.
say something. Ayushi, I want to add something.
Sure, ma'am.
Mutations in certain genes like USP26 have been linked in both infertility and RPL. I'm talking about the husband, and paternal genetic polymorphism and epigenetic modifications can also contribute RPL and chromosomal anomalies also. And paternal lifestyle and health status can also affect the recurrent pregnancy losses, and elevated oxidative stress in semen measured by reactive oxygen species has been associated with RPL. And one study found that men with normal semen analysis but RPL partners had a significantly high incidence of sperm DNA damage, as we can see by DFI.
Sure. Thank you, ma'am, for the valuable input. So moving ahead, Mrs. B has had a live birth but was complicated with early onset preeclampsia, as we can see in the history. In this background, Shipra ma'am, does any particular cause raise suspicion?
Thank you, Ayushi ma'am. I was very eagerly waiting for my turn. I want to thank the organizers for including me in this panel discussion. Basically, it's a kind of adrenaline rush to be a panelist in front of my mentors who have grown me up, who have from being a toddler. Thank you so much. Now, talking about the case B. So, as we focus on to the ops history, we just can't. Sorry, ma'am. So, as we focus on to the obstetric history, we just can't miss to raise the suspicion of antiphospholipid syndrome, the diagnosis of which has got both the clinical domain comprising thrombosis or the pregnancy complications, and also the laboratory domain, that is the presence of specific antibody like lupus anticoagulant and anticardiolipin antibodies and anti-beta 2 glycoprotein. Pregnancy domains include more than one fetal death at or beyond 10 weeks, more than one premature birth less than 34 weeks, and more than three consecutive embryo losses. And the diagnosis is made if at least one clinical criteria and one laboratory criteria are met. This is the Saparo's criteria. And now there's also ULAR APS criteria, wherein they assign points to different clinical and the laboratory domain patients. And the patient is classified as having APS if they accumulate 3 points in both the clinical and the laboratory domains.
Sure. Yes. Thank you so much, Dr. Shipra. So here we can see that, of course, one criteria is required from the clinical and one from lab. This is the modified Sapporo criteria we are aware of. And recently, the Society EULAR European League Against Rheumatism, as conjunction of rheumatology with obstetrics is increasing. We are seeing that a lot of new parameters like echocardiography for the mother or factors like thrombocytopenia in the CBC reports are also being interpreted with a lot of caution. Because it can indicate future rheumatic disease, especially with reference to APLA as well. Thank you, Dr. Shipra. So we move ahead. 3 weeks post her last pregnancy event, that is the first trimester miscarriage, Mrs. B presents to the OPD concerned with her poor obstetrical history. Somebody had ordered her APLA profile outside, and the results of which are as follows. Her PTT was high, 41 seconds, as compared to the control of 35 seconds. Her lupus anticoagulant test was done, which was negative, and the antiphospholipid antibodies, as we can see here, is 18.93, which was reported as high. So my question to Namita ma'am is, was the APLA profile ordered at the correct time?
I believe the APLA profile should be ordered 6 weeks after her previous miscarriage. So this has been done earlier, which can give us fallacious results because of transient APLA positivity or infective reasons.
Yes, ma'am, absolutely. So when to order the test is also of utmost important. Any of the postpartum changes or pregnancy related changes should be known from the body before we order. So 3 weeks should not have been the time interval where this APLA profile should have been offered. Thank you, ma'am. Anita ma'am, I would want to know that the reports available in front of us are for this lady APLA profile. Do you think the report is complete, or are we missing upon any of the parameters?
Yeah, this report is not complete. This APLA syndrome, APLA should consist of lupus anticoagulant, then IgG, IgM, anticardiolipin antibody, and anti-beta 2 glycoprotein. This is the complete profile.
Yes, ma'am, absolutely. The other two antibodies were missing in the previous profile, and as we can see, the significance of the antibodies, ma'am. So lupus anticoagulant has the strongest association, and the other two antibodies also give us information which was not available in the previous profile.
Yes.
So what we saw as APL being reported in this report here. So the APL is actually a very broad umbrella term wherein a lot of antibodies come under. So this reporting of APL, it has fluctuation of titers, is subject to positivity secondary to infections, and there is a lack of standardization. So once we are ordering the APLA profile, we should particularly jot down the 3 antibodies that Anita ma'am has told us, because APL as an umbrella term is still being done by a lot of labs. Some of these antibodies are under investigation and research purposes, so they should not be done as under the umbrella term of antiphospholipid antibodies. The other point here is that a lot of times PTT is reported to be high, but the net final lupus anticoagulant is absent. So what we need to know is that alone PTT does not play significance unless until we are looking for some other causes like maybe liver disorder or any other bleeding diastasis. Otherwise, once we have to see for lupus anticoagulant, the ideal test is to dilute it with Russell Viper genome test. So we as clinicians have to actually see the DRV screen time and then what is the final interpretation of lupus anticoagulant. Yogita ma'am, what will be the treatment plan for this lady once we ordered the interval APLA and it actually came out to be positive with anticardiolipin IgM being positive in high titers?
Yes, this patient who already have all the reports in hand, and of course, the interval apply is done after 6 weeks of last miscarriage, and we have to confirm this after repeat the test after 12 weeks. So we should have 2 reports with the positive, but the treatment goes like reassurance and TLC, like it was said before, tender loving care and reassurance. And the medical treatment will be like we start the folic acid since in prenatal period, and aspirin comes positive. And like Dr. Paki said, we can start the aspirin even before we confirm the pregnancy.
Yes, ma'am. Absolutely.
Yes.
I would request Latika ma'am to please give her inputs on what are the clinical problems that many a times we do come across and we offer the woman on LMWH. What are the clinical problems that we face on following up these women or explaining to them how to take the injections, what precautions have to be taken? I would request you to elaborate on the counseling of women who are advised LMWH for APS. Latika ma'am, am I audible?
Okay, sorry, yeah. So counseling is very, very necessary. Once the lupus anticoagulant comes positive, we have to give the LMWH during the pregnancy daily or even before the pregnancy occurs. We do, as we do in IVF, after embryo transfer, we start the LMWH. We should ask the patient to take these injections daily. And the counseling is very, very difficult. Patients are very much afraid of taking injection daily, but we have to ask the patient because without these injections, this is not possible. So once we have the positive report, we have to definitely give the injections daily, and we have to monitor the parameters whether she is having bleeding during taking these injections. And as we see in our IVF patients, the patient has bleeding. She has crossed 12 weeks or 14 weeks. For 2 or 3 days, we have to hold these injections whenever she has a bleeding. And as we do, as the low aspirin doses, we hold for 2 or 3 days. Like this, we do.
Yes, ma'am, absolutely. Because clinical education of the woman taking these injections is very important. Care of the site of injection, when not to take the injection, when to report to your clinicians, that does form an important part of counseling the lady, whoever is being advised, UFH or LMWH. Thank you, ma'am. So in continuation with the thrombophilia series, APS we discussed as the acquired thrombophilia. What is the role of testing for inherited thrombophilias, Anita ma'am? Should we be offering it to all women detected with RPL, or is there any additional history that can guide us in this scenario?
One, obstetric history, as we have already seen that second trimester obstetric history with if placenta histopathology or ultrasound findings show placental thrombosis, APLA is positive. In these cases, we can go for a thrombophilia test. But one more I wanted to mention is that family history and patient's previous history is also very important. If the patient has had an episode of DIC or more than one blood clot by the age of 40, as RCOG mentions that very high risk groups are patients with venous thromboembolism or long-term warfarin usage or antithrombin 3 deficiency or previous recurrent or unprovoked venous thromboembolism or family history of venous thromboembolism or estrogen or pill induced venous thromboembolism, then these patients should be told that there are a lot of tests which can be done and will provide some answers like factor 5 lead-in deficiency or prothrombin mutation, protein C deficiency, protein S deficiency. But ideally, these tests are within a research context because the treatment will remain unchanged and the results will also be, we cannot be guaranteeing them a sure shot result even with the treatment. So,
Yes, ma'am.
yeah, it is a category 2 as RCOG recommends.
Absolutely, ma'am. So, particular guidance has to be there from either obstetrical history or personal or family history to initiate this testing, which is expensive and which should be focused. Ruchi, ma'am, what treatment options and expectations should the lady be counseled before proceeding for testing thrombophilia?
Before starting the treatment for the inherited thrombophilias, we must counsel the patient about not the 100% predictive value of these tests or these treatments. As we are giving these patients almost till her end of the 8 months of the pregnancies, we are going to give her low molecular weight heparin. So we must tell the patient about how to use them, what are the side effects, when to stop, and how to take them. And also, we cannot guarantee the outcome even if she takes these medications regularly.
Absolutely, ma'am. So we have to keep this into perspective once we order the test and if at all the tests come out to be positive. Thank you, ma'am. For Mrs. C, the products of conception were subsequently sent for karyotype. We are aware that her NIPT was normal. She had a miscarriage at 16 weeks. So, Dipali ma'am, is it okay to order genetic testing of pregnancy tissue with history of only 2 pregnancy losses?
Yes, we should order according to recent RCOG guidelines. Initially, it was said that there should be more than three abortions, but now it is recommended that karyotype should be offered, or karyotype or microarray should be offered on the tissue of products of conception on subsequent miscarriage of any. Actually, in second trimester, okay, this is second trimester miscarriage, so they have said that after two losses, third tissue should be. I was saying about first
Yes, ma'am.
trimester loss.
Dr. Ayushi,
Yeah.
is Dipali audible? Dr.
Hello?
Yes, ma'am. So, yes, Dipali ma'am, you're audible.
Yes. Thank you so much. For any
So,
second trimester
a second
miscarriage,
trimester miscarriage, and we saw Mrs. C having a second normal NIPT result as well. Yes, Dipali ma'am. So, it is correct to order the test with 2 losses. Ma'am, we would want to know what advantages does genetic analysis offer once now the pregnancy is already lost. What does this analysis offer?
so if the products of conception are shown to have some genetic abnormality, we should then investigate the parents if they have some balanced translocation, and we can do that with the parental karyotype, not microarray. So with karyotype, we can see if any balanced translocation is there in either of the parents. So, and then we can counsel about the risk of recurrence in those like subsequent pregnancies, and accordingly prenatal or like PGD can be offered to them. Yeah, again we can better counsel then about recurrent risk, and then again prognosis of the baby.
Yes, ma'am, absolutely. And one of the most important things is they provide an answer in a lot of couples. So the chances of people pursuing non-evidence therapies in case there is something which is diagnosed in the POC report, that is important to stratify our future treatment as well.
Yeah, many of the times patients always blame, like we had gone to travel, and even in some couples, so it is very difficult to tell them what was the reason. But then we get the specific reason. Okay, your baby had this abnormality, so it was not a fault of obstetrician's treatment or some wife's fault. So it is.
Sure, ma'am.
And one thing, Ayushi, I just want to say one thing. Yes, if elderly primary and if she goes for NT-NB scan, ideally one should go for the one should see the uterine artery Doppler as well as ductus venosus, because in cases of elderly primary, she is more prone for PIH, and at that time only we can measure the uterine artery blood flow, and we can detect few things which she might develop later on.
Yes, ma'am, absolutely. So,
Yes.
comprehensive first trimester evaluation is important. In
Yeah.
continuation, Neha, ma'am, I just wanted you to elaborate what are the clinical difficulties we face as clinician once we ask the woman that now the pregnancy has been miscarried and we want to offer tissue for a certain kind of genetic analysis. What is the perspective of the couple, or what difficulties do you face as a clinician in trying to counsel the couple for this test? Because now whatever bad has to happen has happened. So, could you
Yeah.
please that perspective?
No, it's very nowadays, earlier when we were in practice for 20-25 years back, hardly it used to be matter. But nowadays, even after one miscarriage, miscarriage, patient is very much anxious. Ki why this happened? Oh, I was traveling, I was taking so much of care. Even then it happened. So earlier we used to only go for the investigation after 2 to 3 miscarriages, but now even after one miscarriage, patient really is anxious, and really they ask us to go for all investigation once they plan pregnancy. Second plan, I mean, they are going to plan pre-pregnancy level, so they just want to rule out every aspect. Even then the patient develop few things. So at that time we say we are sorry, we can't do anything for this, but really counseling is takes part, so it's very difficult to counsel such type of patient.
Yes, ma'am. Thank you for the clinical perspective. As we can see here, although karyotyping is a simple test, but it is limited a lot by failure of cell culture, especially because it requires live cells. And once the miscarriage has happened, then there is the subsequent procedure of expulsion. The cells are dead by that time. So karyotyping has a higher failure rate. Array-based microarray, what we call in common terms, has come out to be the most recommended method. But yes, costs are definitely a limiting factor. And the other thing is, what if something comes out in array? Then we require a collaboration with a fetal medicine or a genetic person to discuss the reports in detail.
Yes.
Dipali ma'am, we would be utilizing your skills as fetal medicine specialist further. What do you feel? Which scenario of karyotype is more reassuring once we have to prognosticate for RPL? Would it be a euploid or an aneuploid report?
If it is a euploid report, like on this is parental karyotype or fetal?
This is the POC, ma'am, pregnancy tissue karyotype that is available here.
Yeah, so aneuploid is the most common cause of first trimester. More than 60% are because of, and most common is trisomy 16. So they are the most common causes. So prognostication wise, if the parental karyotype is normal, then less than 1% chance of recurrence is there. So prognostication wise, we should reassure the couple that it is not that very less chances are there for recurrence. And again, microarray would be more beneficial in this case because as you said that live culture is not possible, live cells are not there. So microarray would be more informative in this case.
Absolutely, ma'am. So here, once our pregnancy tissue is saying that there is some kind of aneuploidy, we know that, okay, this was some problem in the current baby, and further investigations are accordingly limited or channeled. But if the fetus is euploid, then our mind works in the region of maternal causes, or are there any other causes which are causing the recurrence of losses? So euploid actually opens up that Pandora's box where you have to dig into a lot many causes. And as ma'am told, if there is any kind of unbalanced translocation or report that is coming on the product of conception, then yes, parental karyotyping has to be done, because either the parent could be a carrier of some kind of balanced translocation that is coming now as unbalanced in the fetal tissue. Thank you, Dipali ma'am. Pallavi ma'am, there are specific criteria when the couple karyotyping should be done, and why so?
Blood karyotyping of both the parents should be offered in the cases when the pregnancy tissue report showed unbalanced structural chromosomal abnormalities, or when the testing of the pregnancy tissue was inconclusive, or when the pregnancy tissue was not available with us. Parental chromosome rearrangements are associated with the recurrent miscarriages. The risk of the subsequent miscarriages depends upon the type of the rearrangement, whether it is the Robertsonian inversion or the reciprocal. The highest recurrent pregnancy losses are associated with the reciprocal, followed by the inversion and followed by the Robertsonian. So we have to do the couple karyotyping in the cases where the patient is facing the recurrent pregnancy losses.
Yes, thank you, ma'am. Pallavi ma'am, should we offer PGT-A to Mrs. C for RPL prevention in next pregnancy if she opts for IVF again?
Definitely, we should offer PGTA to the patient as the patient age is 40 years. As we all know, as the maternal age advances, the quality of the oocyte decreases out, which results into the aneuploidies of the embryos. So we have to do the PGTA, that is the pre-implantation genetic testing for the aneuploidy. The rationale is to identify and transfer the genetically normal embryos, which will decrease the chances of recurrent pregnancy losses. It should be done on the day 5 of the embryo, that is the blastocyst. We can also go for the PGT SR, that is the PGT structural rearrangement testing for the embryos.
Yes, ma'am. So it has to be individualized, and as PK ma'am has already said that until definite evidence builds up, we have to individualize our approach. And at the moment, yes, evidence is lacking for offering for prevention of unexplained recurrent miscarriages. But recent trials like SART codes have come out with improved live birth rates in couples with recurrent pregnancy loss undergoing IVF frozen embryo transfers.
Ayushi, I want to add something.
Ma'am.
The BGT is in couples with structural chromosomal defects might reduce the number of miscarriages experienced prior to a successful live birth. But PGT is not routinely advised since the likelihood of a pregnancy with an unbalanced karyotype surviving into the second trimester is low. It is only 0.8%. And further evaluation has to be done.
Yes, absolutely, Latika ma'am. As we discussing second trimester miscarriages, Shipra ma'am, any other causes that have to be kept in mind? We have had an elaborate discussion, so we just want to know the causes and investigation of choice for them.
Basically, it's recommended for all women with recurrent pregnancy loss to have assessment for uterine anatomy. 3D ultrasound has got high sensitivity and specificity. But in case like where we want to do tubal patency as well, sonohysterography is more accurate than hysterosalpingography.
Yes, Dr. Shipra. And the concluding word here would be that 3D ultrasound in hands of an experienced operator works as good as MRI.
Yeah. 3D ultrasound is as good as other scans. If other modalities, 3D really gives a good picture.
Yes, ma'am.
So we have had a discussion on septal dissection. Latika ma'am, I would just want your final word on what we should be doing once we come across. What should be, these are the recommendation and guidelines I say, but what is your clinical final say on septal dissection for RPL?
If I speak my experience, if I see septum in any of the patients of IVF, I will definitely go hysteroscopic resection because I have seen better results when we resect this septum. And we do have the pregnancy with septum, but the more chances of having miscarriages are definitely there.
Yes, ma'am.
So I saw one of my patients who had septal resection with a very renowned doctor from Delhi, and still she was not able to conceive. Then I saw her, I did hysteroscopy. She was having little septum was still there. So I asked her to go for the again resection. I did resection, then she conceived. So my experience is to resect definitely, for sure.
Sure. Thank you, ma'am. On inquiring details about interval workup for Mrs. A, her TSH levels came out to be 3.5 and prolactin was 5. No clinical signs and symptoms of either of the pathology were present. So, Namita ma'am, should we be doing the complete endocrinological profile for all women, thyroid, prolactin, sugars?
Yes, we should do it for all because this is a very basic investigation and it will definitely give us some insight into how to proceed further. If TSH levels are high, then we can proceed further with anti-TPO antibodies, T3 and T4 levels.
Yes, ma'am. So, ma'am, they was started on thyroxine 25 micrograms at TSH of 3.5. What are your views on therapy? Any role of TPO antibodies to subclassify the lady?
If she is subclinical hypothyroidism and without TPO, then she does not need levothyroxine therapy. But even if she is subclinical but with TPO positive, definitely pregnancy results and carrying a pregnancy does improve with when she tests TPO positive.
Yes, ma'am. So the basic idea is euthyroid woman, even if the antibodies are there or aren't there, doesn't matter. You do not have to treat such women. But in cases where there is subclinical hypothyroidism, especially when it is less than the upper limit of reference, which is usually 4, then we can triage using anti-TPO antibodies. And most important would be regular TSH measurement from 7 to 9 weeks in cases of TPO positivity or in cases of subclinical hypothyroidism. Thank you, Namita ma'am. Anita ma'am, Mrs. A was started on progesterone therapy as well from her 3rd loss onwards. Does progesterone help in RPL? We have had some kind of discussion on it. So you just want what is your perspective, ma'am?
Yes. As already very well explained by Dr. Picky Saxena, that progesterone does play its role, and ideally it should be started 2 days after ovulation, and it should be continued. If pregnancy occurs, then it should be continued till 20 weeks. And it has different kind of role, like it helps in placental formation and functioning of placenta. It has role of uterine relaxant as well, and then it acts as an immunomodulator. So in a way, practically we do start in recurrent. Yeah.
Yes, ma'am. So as
I'm in favor of that.
sorry, ma'am.
No, I'm in favor of starting progesterone, giving progesterone support, definitely.
Absolutely, ma'am. So a lot of work has been done on progesterone in obstetrics, in recurrent miscarriages. Initially, there was this promise trial which said that progesterone does not have a role in cases of unexplained recurrent miscarriages. But a subgroup analysis was done and this PRISM trial.
तुम्हारे लिए देखना
This PRISM trial is available, which now says
देख
that
लेना
strategy.
लेके आना पहले देख के आ
So we have to stratify women based on this presentation. That is, a woman who has had a history of miscarriage. Now, in this pregnancy, she is presenting with vaginal bleeding. In such cases, it is a good idea to start progesterone, and what they recommend here is only the micronized progesterone that can be used as twice daily until 16 weeks of gestation. So NICE has also come up with very specific recommendation. This is not to be used in women who do not have bleeding, even if they might be having recurrent miscarriage. So the specifications are that she has had one or more miscarriage, she is presenting with bleeding in this pregnancy, and then that is where we can start with progesterone support, and that too for micronized, not for the injectable ones. It is for the micronized progesterone here that they have given this statement. So thank you, ma'am.
Ayushi, if patient doesn't bleed, then it shouldn't be started.
At the moment, start it. Is what this says that in cases of unexplained miscarriages, progesterone did not play much of a difference. And here, I suppose we can use our clinical discretion to Hello, Anita ma'am, am I audible?
Yeah, you were not audible, huh?
So ma'am,
so
here,
in case of bleeding only, we can start, no? We should start.
Here they
Spotting
say of bleeding only is what, or if we have second trimester miscarriage, which was supposedly in the form of cervical insufficiency. Apart from these two indications, at the moment, unexplained miscarriages, progesterone, yes, it does. It has not proven a direct efficacious role.
Okay, thank you.
Thank you, ma'am. So, Yogita ma'am, this was one of the torch panel that has been offered to the lady, Mrs. A. Should it be done or would have been done?
Actually, torch test is not recommended in RPL cases. But in the report, I can see the IgG is positive mostly, and which is an old infection, not the current infection. So I don't think it has any role in RPL. And there is another report, next slide. And there is another report which says the endometrial biopsy is taken and Mycoplasma genitalium is positive. So I would say in this scenario of case A, when there is a 4 first trimester abortions, maybe there is infection plays a little role. Overall infection responsible for RPL is 0.5 to 5% only, but we should not leave any stone unturned and we should check for infection. And we do take swab from high vaginal swab and endometrial biopsy, like they say, go for chromohysteroscopy and take a biopsy, and then we treat it. If it is not tuberculosis, then it's like we treat it with antibiotics like doxymetro, and that's it. We can go ahead with this next pregnancy.
So
even bacterial vaginosis, bacterial vaginosis is quite common.
Yes. So taking biopsy is important here, like swab. Yeah.
Yes. And ma'am, at the moment there is one trial called SERM, chronic endometritis and recurrent miscarriage. It is an RCT which is ongoing and which is actually to find out the answer if doxy given prior to conception can improve the number of ongoing pregnancies and live birth. So as the clinical experience builds up and data builds up, yes, chronic endometritis in future and infections in future need to be treated as an entity which cause RPL.
Yes.
Pallavi ma'am, any role of ANA testing which is now being frequently done in cases of RPL?
Since the positive ANA titers are related to the autoimmune diseases like SLA, Jorgen syndromes, or the systemic sclerosis, but still the relationship between the positive ANA and the RPL is still controversial. The prognostic value of ANA for the subsequent pregnancy is also clear, and the mechanism of action that how does the positive ANA anti-nuclear antibody causes the pregnancy losses is still controversial. So it still requires the basic studies to go further for the investigations of such patients.
Yes, ma'am, absolutely. At the moment, they say it is for explanatory purposes, but as we all know, as clinicians, we will never treat the lab reports. We treat the patient. So it is important that if any lady who now had been ordered ANA comes out to be positive, we take a detailed history or we refer to a rheumatologist, or in case we see the ANA profile in front of us, and if there are certain antibodies like SSA, SSV, which are ROLA, they might have implications in future when once the lady conceives. So yes, ANA at first hand offering requires our clinical discretion, and once we have offered, we see the reports, it becomes important that we interpret it in the context of present and the future pregnancy the lady is going to embark upon. Thank you, ma'am. Ruchi ma'am, immune testing, NK cells, uterine decidual testing, all are coming into lot of news now. So does immune testing play any role in RPL?
Immune testing for NK cell, target T cells, dendritic cell, HLA testing. These, as far as now, at present, in present scenario, has only theoretical value. Actually, they are not being tested regularly.
Yes,
no
ma'am.
current guideline tells us that these should be tested.
Yes, ma'am. So these all are, I suppose, the ongoing research parameters, and maybe outside of a research context, once they are established, we would go ahead with HLA, cytokine, and NK cell testing. Dipali ma'am, could you please enlighten us with any of the recent advances in therapy for RPL that we are now using in the clinical context? And I suppose we have had discussion on IVIGs and so.
Yeah, they are all like under trial, and they are quite costly also. So IVIG and also some even they inject some the plasma this thing also, but actually they are all not proven, and so we can't say that they can be used till not in the protocol.
Yes, ma'am. So at the moment, a lot of research, but we have certain drugs like hydroxychloroquine, which have started coming into clinical practice. At the moment, not much of literature supports it, but we have certain entities like seronegative APS, wherein the lady will have a negative APLA profile, but her obstetrical history fits right into APS. Or we have some women who are known case of APS, they have received prophylactic heparin, aspirin, still they went on to miscarry. These are certain very specific subset where you can add HCQ, steroids, or immunoglobulins maybe to carry on with the pregnancy. Latika ma'am.
Yeah, I would also like to add one point that those patients who are known cases of autoimmune diseases like scleroderma or rheumatoid arthritis and ANA positive, if they are already on HCQ, then HCQ does prevent against recurrent abortions. It is very much protective in them.
Ma'am, we have to educate them that HCQ is not a teratogenic drug.
Yeah, it should be continued and it is protective.
Yes, Latika ma'am, any of your experiences with HCQ, any woman you have put up on HCQ pertaining to the obstetric history being poor?
No, I don't have an experience with this. Sorry.
Ma'am, sure ma'am. Neera ma'am, anything from your side for HCQ?
Yes, one or two patients, they were of rheumatic and they were on SCQ, but they continued pregnancy till full term with the same dose.
Yeah, sure, ma'am. So it is important that
Yes.
we can see
Yeah.
that our newer options that are coming, but yes, in a lot of specific scenario.
Yeah.
Yes, ma'am. And therapies like IVIG can improve live birth rate is what is upcoming. But yes, a lot of trials and data at the moment do not recommend. Although ESHRE in 2022 update has said that use of repeated high doses of IVIG very early in pregnancy may improve live birth rates in women with 4 or more unexplained RPL. That was based on a high quality RCT that was done by Yamada et al. But at the moment, yes, we have to be very specific about the uses. Shipra ma'am, any role of lifestyle modification?
That is very important.
Yes, ma'am. Shipra ma'am, are you there? I suppose we have lost connection with Dr. Shipra. So this
Hello?
has been.
Am I audible?
Yes, you're audible.
Yeah. Obviously, there have been improved outcomes associated with lifestyle modification, both obesity and underweight. They are bad in all the obstetric cases. Limitation of alcohol, caffeine, they are always seen to improve the pregnancy outcomes. However, till now, there have been insufficient evidence for exercise. And also, the most important is the psychological support that a patient with RPL should be offered.
Sure. Yes, Dr. Shipra, this has been the topic of discussion actually of utmost importance. And I would request Anita ma'am to please throw some light on how to counsel the dismayed couple, because unexplained RPL is, yes, a definitely big chunk. Anita ma'am, are you there?
Here only, I think tender loving care is required because we have to ask and we have to counsel couple very carefully because already she has suffered twice or thrice. So I think we should take care of them and tender loving care is required.
Yes, ma'am, because the impact is nothing less than a PTSD for a couple who has been
Yes.
child. So this is common from all societies, and let alone societies. This, I think, we as clinicians have the utmost responsibility to continue ahead with the tender loving care.
Yes. Because it's very difficult because patient spends so much matlab monetary loss on the investigations as well, and even then they don't get anything, then they really become frustrated. So at that time counseling and loving care is required.
Yeah, and I would like to say that many a times Neera ma'am and Mridula ma'am, all the seniors would agree that we also think that how come we have not done anything and how come with previous 4 or 5 losses and the pregnancy now is continued with us. So maybe ki tender loving care only works.
Yeah, this happens very much. This happens very regularly.
Yes.
Yeah.
Thank you, ma'am. So just a final word that the once these ladies conceive, it is definitely a happy news, but the journey is not easy. It has been seen that women with RPL, they subsequently have a lot of perinatal difficulties, antenatal peripartum difficulties as well, hypertension, PPROM, fetal growth restrictions. Journey has to start right from making them conceive to taking them along something called as the high risk pregnancy. But yes, with beautiful outcomes. So thank you, ma'am. I would request our experts to kindly sum up on our panel discussion.
First thing is this, Ayushi, congratulations for such a nice
Yes, very
panel.
nice, very
Very
nice.
nice. And I think you have covered each and everything. And my message is only this, कि we have to counsel the patient and we have to write investigations accordingly. Because at the same time, we cannot write battery of tests to the patient. First thing is clinical history, examination, and then investigation, step by step. Then only we can manage our patient.
So Ayushi, it was a fantastic webinar. You conducted it very, very nicely. I think national level webinar was this because of Ayushi only. So
True,
congratulations,
true.
heartiest congratulations.
Yes,
And
true.
I should say, to save our skin, we should write all the tests in the paper, but ask few tests which are required, definitely required. You ask the patient to go for these tests only and assure the patient and counsel the patient. This is very, very necessary.
Very well conducted, Ayushi, and
Thank
you
you.
have covered everything. And in this scenario, in today's practice scenario, we need to widen our shoulders. So we have to broaden the horizon, including all the specialists. We should not be, trying to be master of all, jack of all and master of none kind of a thing. So since you are the expert for fetal medicine, we should be including you and sending you to the fetal medicine patients or to Dr. Dipali, who's there also, who has been here with us. So very nicely conducted, and very nicely conducted by Dr. Ruchika and Dr. Shashi, and all the panelists have done a wonderful job. So thanks for including me over here.
Thank you, ma'am. Thank you all seniors for your kind blessings. It is with your blessings that young juniors like us get the ability to grow. I would request the force behind this webinar, Ruchika ma'am and Shashi ma'am, to kindly take over the platform.
Very nice.
Very interactive, very interesting interactive session. And congratulations, Dr. Sashibala, Ruchika, Ayushi, and all team.
Ruchika, well done.
Thank you, ma'am. Thank you, ma'am, for all.
Ruchika has done so much of efforts. She called me so many times.
Ruchika and Shashi
Congratulations, Ruchika and Shashibala also.
It is with your all blessings that we are able to conduct these type of activities. And now I would like to invite, last but not the least, our very dynamic Dr. Mridu Madam. She is professor and to propose a vote of thanks. Over to you, ma'am. She is the treasurer UPIFS and she is a professor and unit head at SRMS IMS. Over to you, Mridu Madam.
Thank you, Dr. Ruchika. It's my privilege to propose vote of thanks before you all. And first and foremost, I would like to thank the organizing team, especially Secretary IFS UP Chapter, Dr. Ruchika Goyal, and former Secretary and Advisor IFS UP Chapter, Dr. Shashibala Arya, for their untiring efforts to organize this webinar. In collaboration with Bareilly Obs and Gynae Society, President Dr. Latika Agarwal, Secretary Box Dr. Anita Nath, and Joint Secretary IFS UP Chapter Dr. Mridula Sharma. And this could not have been possible without support, vision, and able guidance of our President, Indian Fertility Society, Dr. Pankaj Talwar sir, and Secretary General IFS Dr. Shweta Mittal, along with our Founder Secretary IFS UP Chapter Dr. Professor Colonel J.K. Goyal sir. So with this, all I extend my heartfelt thanks to all and a lot of gratitude and respect to all the dignitaries, all the distinguished faculties, especially Dr. Piki Saxena, Dr. Deepti Saxena, all chairpersons, panelists, moderators, and panel experts, Dr. Neera Agarwal and Dr. Latika Agarwal, who all took their time out of their personal and professional life and shared their valuable insights. I'm sure this webinar will not only act as a catalyst for bringing change in their approach, but also help in updating their knowledge. Last but not the least, my deep sense of appreciation to all the participants for joining this webinar and making it a grand success, as well as the IT team, not only of SRMS, but also from Delhi for their successful conductance. Thank you. Have a nice day.
Thank you, Dr. Shashibala, and thank you, Dr. Ruchika, and SRMS team, IFS team. Very well done.
Thank you, ma'am. Thank you.
Ruchika, bye-bye. So done. So well done. Really nice.
Nice to see you, Dr. Mridula, Dr. Latika.
Hey.
I miss box meeting, so nice to see you all here.
मृदुला मैम आपका वॉइस
है बॉक्स मीटिंग कल मिलते हैं
मैम
कल है
आपका
box-
वॉइस वो है बंद है
अच्छा
I was saying Yogita must come for the meetings.
Yeah, sure. We'll
Yes.
try.
And
We have another
I think
physical
this
meeting
webinar is a
tomorrow.
very good platform when we are not able to go physically. So here we are on the virtual platform. At least we are able to look at each other and have a wonderful
Right.
academic session.
Right.
As a president,
And
both
Goel
I'm
sir is
inviting-
also here. Goel sir is also here. Namaskar, sir.
Thank you, Dr. Shashibala and Dr. Ruchika, for everybody, for excellent is the word for it.
Yes, it was an excellently
all respect.
organized.
In all aspects, it was excellent.
Dr.
Wonderfully
Goel,
chosen
namaskar.
topics.
नमस्कार
Hi.
मैडम, नमस्कार. और कैसे हैं मैम? ठीक है?
ठीक है, बढ़िया. Nice.
Namaskar, sir.
So I am inviting all of you for tomorrow's physical meeting, and we will be discussing PIH. So all come in large numbers tomorrow. Shashi, Ruchika, all of you should come.
Yes.
शिप्रा कैसी हो शिप्रा?
गुड इवनिंग मैम. मैम अच्छे हैं मैम.
Shipra is excellent always.
थैंक यू. गुड इवनिंग सर.
Dr. Dipali, have you left?
She was in OT, ma'am. Actually, she joined from OT. So busy. Okay, उधर.
Thank you, Deepti. Your talk was very informative.
And thank you, PK ma'am.
थैंक यू मैम.
Bye bye, Shashibala. Bye.
Bye, ma'am. Bye.
Okay.
Thank
Bye
you,
bye.
ma'am.
Bye. Thank you, everybody. Thank you.